Sir, 5 minutes, sir.
Attendance, good, very good.
Good morning, everybody. I, on behalf of Indian Medical Association Mumbai branch, welcome you all for today's program. Today's program is like a cassata ice cream. It's a combination of two semi lectures, then JJ Merchant oration, and elocution competition, IMA elocution competition. So I'm very happy that the number of delegates have joined in large number as usual. So we will be happy to give these fees to you. And today's programs, today's lectures are also very interesting. One lecture, of course, Dr. Jitesh Bhai will talk about that. But important is that, choose the antibiotic right. That is more important. Most important topic that we have chosen. It is like choosing a life partner. If it is proper, then only it will work. Otherwise, there may be a problem. It may cause some adverse reactions. And that is why a clinician should be very wise enough to choose an antibiotic in a proper way. I think after such a small introduction and welcome to you all, I hand over the mic to our President, Dr. Jitesh Mehta, for his presidential address.
Jitesh, unmute. Good morning, President sir.
Jitesh, unmute kar. Jitesh. Jitesh, unmute.
He's in the IMA, so that.
Yes, yes, we can hear you now.
Okay. Good morning, everybody. And thank you very much.
President sir, good morning.
Yes, so nice to see our observer observing everything. Thank you very much. Okay, so I welcome all of you on behalf of Indian Medical Association Mumbai branch to this variety program. We have got a webinar, then we have got a JJ Merchant oration, and of course followed by the IMA Elocution competition, a very popular event that happens every year at IMA Mumbai branch. Since last 2 years, we are holding it online, and I'm sure the participants are also all ready. So friends, yesterday was a great day, a very, very pious day. And yesterday, I'm sure you must have all seen one of the biggest statues of Ramanujan has been unveiled by PM Modi at Hyderabad. And it is a moment of great pride for India, having such a big statue, one of the biggest in the world sitting statue, and that goes as a feather in our cap. Now, Indian Medical Association also wants people to join. So many new consultants are there, and we all want them to join Indian Medical Association, whichever branch they may be eligible to join. But I request all of you listening to me, please join the Indian Medical Association, become a member of the IMA, because IMA is the only body that always fights for the welfare of the medical fraternity. Recently, you must have seen the NEET PG counseling, which was stalled for a long time, has been ultimately started because of efforts of IMA and the medical students, of course. So it's always IMA full support, backing up all activities of the junior doctors and the MART people and all over, and even the welfare of the practicing doctors. Whenever there is a problem, IMA is always there to stand up and support them. So friends, join IMA. That is a Guru Mantra, and make IMA big. With this, I hand over the proceedings to Dr. Anil Awad. He shall further the proceedings. We can have the speakers, and the introduction is being done by our Dr. Kashyap Dakshini, first speaker. He is there with us. Over to Dr. Anil Awad. Thank you.
Yeah. Thank you, President sir. We already have 392 participants, and it's a very good thing that IMA arranging program almost every week now, which will enable the delegates to get more points, credit points for their renewal. We begin with today's talk with Dr. Rohit Pai. I don't think sir has joined.
Sir had I think he was going to take some emergency rounds in the Bombay hospital.
Yeah.
So the person from INTAS, he had talked. Has he forwarded the slides to you?
No. Okay, by that time we'll just finish with the introduction, Dr. Mehta.
Yes, start the introduction. If not there, then if second speaker is ready, start with the second speaker.
Yeah. Okay. Just a minute.
Okay. Will be joining.
Dr. Jitesh.
Yeah, he's joining in 2 minutes.
Yeah. That is, I also got the phone call. He's joining. Okay. By the time we'll finish with the introduction, I request Dr. Kashyap Dakshini, member of IMA CGP Mumbai sub-faculty, to introduce Dr. Rohit Pai.
Good morning, friends. Dr. Rohit Pai is an associate consultant medical oncology in Bombay Hospital and a visiting consultant medical oncology in Nair Hospital, Mumbai. After doing MBBS from Lokmanya Tilak Medical College and Sion Hospital, Dr. Pai did his MD in internal medicine and DM in medical oncology from AIIMS, New Delhi. Dr. Pai then completed his DNB in medical oncology and MRCP, and then also received European certification in medical oncology. He holds a brilliant academic career, securing distinctions and gold medals at all levels. Dr. Pai has also been the recipient of numerous awards at city, state, and national levels. Dr. Pai's fields of interest are GI oncology, head and neck cancer, breast cancer, and immuno-oncology, as well as hematological cancers. Today, Dr. Pai will speak on management of breast cancer. Welcome, Dr. Pai.
Pai is not yet joined. Has he joined? Dr. Pai has joined?
No.
No, okay. Yeah, so by the time
Dr. Jitesh, you can
joins,
just tell something about
I would like to just make an announcement.
competition.
Can I talk, Dr. Awad?
Yeah. I said you can talk something about the elocution competition.
Yes, sir. You can discuss about the activities of the IMAs and the forthcoming programs, conferences, and everything.
Yes. So, as you all know, friend, Indian Medical Association Mumbai branch is a very vibrant and very active association. We have got a plethora of activities happening in our branch. Like we have very regular activities. That is, one is the very Aao Gaon Chale project, where we have adopted a village. We adopt a village and we go and visit that village every once in a month, so that we can have a proper follow-up of all the patients. And due to that, we have got a very good rapport with the patients. We can follow up their lifestyle disorders also. We are seeing such lifestyle diseases even in the remote areas and interiors of India. And it is very surprising, and it is a necessity and the need of the hour to really, keep them looked after. So that is one activity where we are always very regular. We have got a very good team of the Aao Gaon Chale, and they very diligently examine all the patients. They even we have got also medicines available by the support of pharma company, and then we have doctors who are ready and willing to spare their valuable time on a Sunday morning. So that is very important. We always go on one Sunday of the month. So that is one activity. Of course, webinars are the most popular activity of Mumbai branch. The whole 2 years, we have had wonderful webinars throughout. Up till now, in my tenure, this is the 22nd or 23rd webinar in 1 year. So you can imagine almost 2 webinars a month. That is the average we are getting, with more than 4 or 5 speakers, sometimes 7 to 8 speakers. It becomes like a mini conference, and it has become like very popular. We have got uploaded all the talks through the MMC on the YouTube, and you can always go and visit them and listen to all the great speakers. Besides that, we have got like this activity every World Day. We are celebrate every World Day, like World Heart Day, World Kidney Day, World TB Day, and that way we have got all the various World Days which we are celebrating by doing CME programs and any other activity that is fitting to that day. Like, so when we have 26, we celebrate our Independence Day, we celebrate our Republic Day. That is the time when we meet at IMA, we salute the flag and we have a get together. We also have certain times, we have got morning walks where we have a marathon walk going on, and participation is there in large numbers by all our members. So friends, there are a lot of activities.
Sir,
other activities which I would like to say, Dr. Pai has come.
Yeah, he has joined.
Okay, then I will stop short over here and I will request Dr. Pai to take over.
Talk about the conference also, sir.
Yes, I wanted to tell about the conference. Yes, the conference is coming on the 27th of March. The conference which was supposed to be held on the 2nd of Jan 2022 has been postponed because of Omicron, and we are going to meet on 27th of March in person at St. Regis, Lower Parel. So I request all those who have not yet got registered for the conference, do so, contact the office, and there are a few seats left. You can always come and join us for the conference. So with that, I think there is a wonderful, the panelists of the conference. If you have a look at that, wonderful, absolutely, what shall we say? Very excellent teachers are there who are going to talk in front of us. Very senior people and doyens of their field. They are going to share their knowledge with us on that conference day. So I'm sure those who will attend will really enjoy it. Okay, friends, I hand over to Dr. Rohit Pai. Dr. Awad, please take over.
Yeah. Dr. Rohit Pai has already joined. Sir, can you just share your presentation? Your introduction has already been done.
Loaded from your end, sir. I have mailed the IMA as well as to you personally, sir.
Yeah.
Good morning, everyone. Thanks to IMA for giving this opportunity. And today we'll be talking about a general brief overview of breast cancer management.
Go on, sir, you are audible.
Yeah, the presentation is being shared, I hope, from your end.
Anil Awad, presentation आलेला आहे.
Yes. एकच मिनिट. The presentation is not opening here. Just a minute. Sir, you can start talking. I'll just share the presentation. Hitesh, Sharav is there, Sharav?
Yeah.
अनिल आवाड वेळ का लागतोय?
अरे प्रेझेंट सरांचं प्रेझेंटेशन आलं आता जस्ट आलं. ते उघडत नाहीये.
बघ जरा.
हा शरयू डॉक्टर आवड.
हा शरयू
हा बोला सर.
मी IMA ला पण पाठवलंय, जरा सरांकडनं शेअर करता आलं तर बघ.
ओके ठीक आहे.
रोहित पाहिजे.
बसा तुम्ही.
आलंय.
थांबा सर एक मिनिट.
रेडी फॉर आहे.
काल पाठवलेत ना सर तुम्ही
आत्ता
जाताना?
आत्ता
हा.
आत्ता आत्ता रेडी फॉर आहे. आलं.
ओके थांबा.
Mail. I have also sent it to the Rediff account.
या
आला सर.
अनिल
शरयू उघडलं का?
अनिल आया ना देख.
शेअर करू का सर?
हा शेअर कर. शेअर
Please
Share कर
share
तिकडून.
and please move the slides for me. Requesting you to please move the slides for me. I'll say next slide. Please share, ma'am.
शरयू बस तिकडे.
हा शी शेअरिंग.
Okay.
And please move the slides also, ma'am. Please.
Yes, yes, she will move the slide for you.
Yes. Yes. Thank you. Thank you, sir.
Not to worry.
Yes, sir.
शेअर स्क्रीन कर आणि PPT वर जा. PPT ओपन करून ठेव.
हो सर. आणि शेअर स्क्रीन करू ना सर?
हा शेअर स्क्रीन कर.
I hope it is visible to all. The slides are visible to all. Just to make it slide show.
सरांना फोन करा.
Hello.
शरीर खाली जा एकदम. 68% दिसतंय तुला?
Yes, yes. Slide show.
शरीर खाली जा. 68% च्या बाजूचा आयकॉन क्लिक कर.
हा.
हा बरोबर राईट. क्लिक कर.
ओके सर.
अजून झालं नाही. परत एकदा कर.
I think it is.
माझ्या इथून झालंय सर.
हो
ठीक आहे.
ते होईल, थोडं लोड होईल.
शेअर करू.
परत एकदा कर. हा एकदाच कर. हा सिंगल क्लिक कर.
केलं सर. आधीची स्लाइड दाखवतात. होत का नाही? प्लीज नाही न्यू शेअर. ही ऑलरेडी शेअर आहे. इथे क्लिक करू सर. तुम्ही log out करा ना. तो
Resume
Then we can
slide-
proceed like that.
Resume slideshow at the top left.
log out.
तिथे resume slideshow आल्यावर तिथे क्लिक कर, नाही तर वरती.
यहाँ पे मतलब ईमेल पे ले लो, यहाँ से शेयर करते हैं।
हाँ सर, इथे जॉइन करा ना.
या साइडला नाही.
या साईडला.
Yeah, so if it's not happening, I'll proceed.
त्यांचं मागून घ्यायला जमतं?
Okay.
हा सर.
इथं आली आहे का त्यांची?
हो, इकडे शेअर झाली PPT.
झाली आहे ना?
हा.
मग काय झालं? नाही. डॉक्टर विजय. डॉक्टर विजय.
विजय
विजय
करंजकर.
Make it slideshow, please. Click only once. Someone please move the slides for me.
ठीक आहे. आपला आवाज जात नाही ना.
हा तर चार्जिंगच आहे ना.
अरे काय गडबड होते?
Hello.
Just click on the slideshow
Hello.
beside the percentage, and please someone move the slides for me. I would like to start.
Am I audible? Hello.
Yeah, you are audible.
डिजिटल वाल्यांनी म्यूट केले वाटतं सगळ्यांना.
Hello?
तुमचा आवाज येतोय.
नाही, आवाज ऐकायला येतोय.
Hello, sir.
आवाज ऐकायला येतोय.
Sir, let it be. I will just present. Let the presentation be. I'll just present as it is.
नहीं अभी
फोन कर रहा था, आवाज आ रही थी.
पूछो ना,
अरे.
बात करो ना.
अनिल आवाड.
Dr. Awad, can you hear me?
आवाड.
Hello.
Yes.
अनिल आवाड, माझा आवाज येतो का ऐकायला?
हाँ, येतोय.
तो गड़बड़ हो गया.
येतोय ना?
तभी आवाज नहीं जा रहा. इधर से लॉग आउट हो गए.
नहीं, क्योंकि इधर से ना स्क्रीन शेयर नहीं हो रहा.
Sharayu,
लॉग इन हो जाए.
Sharayu,
Nitesh, sir.
you stop screen share. Stop कर तुझं बघू.
आवाजाचा प्रॉब्लेम होतो का?
अनिल आवाड,
हाँ.
माझा आवाज येतो ना ऐकायला?
हाँ, येतोय.
आवाज येतोय सगळ्यांचे. काय प्रॉब्लेम काय? आवाज ऐकायला येतो सगळ्यांचे.
यहाँ सब पॉटी है. डायरेक्ट अपना उधर
रोहिणी?
कैबिन हम लोग करते तो फर्स्ट क्लास होता.
So Sharayu,
सर वही बराबर.
Sharayu,
क्या हुआ, नहीं उठा रहा है? फोन नहीं लग रहा है.
Sharayu,
Hello. Hello.
Sharayu, Jitesh, hello. Hello. अरे शरयू, जितेश, हेलो.
Hello.
Hello. But whatever they are saying, I can't hear. That is the whole problem.
Hello. Am I audible, sir?
त्यांचा आवाज येत नाही सुशीला.
Dr. Rohit, you are audible.
सर ते स्लाइड शो आहे स्क्रीन मध्ये 45% च्या बाजूला.
जितेश,
करेल का?
स्टॉप स्क्रीन शेअर करो. स्टॉप स्क्रीन शेअर करो.
Stop screen share करो. Stop screen share करो. Sir, you stop screen share कर. किधर किया? Stop किया?
हाँ.
उद्या यायला सांगू.
बोला था इधर आके करो. ये लोग पानी का ही नहीं जल्दी.
एक काम करा ना, आपण मोबाईलवरती चालू कर.
Yeah, please. I think we will.
Yeah. Sir, I have shared.
Management of thank you, Awad sir. Thank you so much. Management of breast cancer.
I think let's start properly.
I apologize for the technical issues from my
No
end.
issue.
Yes, sir. Please, next slide, please. So,
Lovely,
worldwide
now started
prevalence
rolling.
and mortality, as far as breast cancer is concerned, if you see, breast cancer is the second most common cancer across the globe. The first is lung cancer. But in terms of mortality, so cancer leading to death, lung cancer still holds the #1 position, but breast cancer is the 5th most common cancer causing death. So even though breast cancer is extremely common, with regards to death, breast cancer is 5th. That means that because of progress in treating breast cancer, the number of deaths are not that much, and because of early diagnosis as well as advances in treatment. Next slide, please. Previous, please. Yeah. According to the next slide, please. According to the Globocan 2018 data, most common cancer in India, even if both the genders are included, is breast cancer. In breast cancer patients, 99% of breast cancers happen in females because females have the glandular structure necessary for milk production and milk secretion, and only 1% of breast cancers happen in male. But still, even in India, breast cancer is the #1 cause of cancer, and it is the leading cause of cancer in urban registries like Mumbai, Bangalore, Chennai. Next slide, please. So there is a growing burden of cancer, and if you compare the scenario of cancer in India to cancer in China and US, you can see that the 5-year survival rate is around 50% for all stages of cancer. This is not for early, it is for everyone. But as compared to that, China and US, it is 80-89%, so much significantly higher. And if you look at the mastectomy rate, so a complete removal of the breast as opposed to a only lump removal, that is the lumpectomy or breast conservation surgery, again, the mastectomy rate in India is very high as compared to China and US. It is very easy to say, I will say next slide. So it is very easy to say that maybe the advances in treatment in India are not as much as those of China or US, but unfortunately we ignore the situation which is there in India. So if you look at the right side of the slide, average age at diagnosis for breast cancer in India is 40 to 50, Caucasian is 60 plus. If you look at high grade cancers with potential for recurrence and metastasis, again, in India, it is higher, 45 versus 38.7%. And the percentage of treatment, a percentage of tumor that don't respond to hormone therapy, again, aggressive tumors, they are called HER2 positive breast cancers or triple negative breast cancers, 30% versus 21%. And inflammatory breast cancer, that is cancer cells invading the lymphatics and causing inflammation rather than a discrete lump. Again, that is slightly higher in Indian setting as opposed to Caucasian setting. And percentage of patients occurring in younger than 40 is 16% as opposed to 6%. Currently, the youngest breast cancer patient I'm treating is 23-year-old. So there is a significant epidemiological difference in patients who are presenting to our cancer centers, to our hospitals in India as opposed to that of the West. The second thing is, many a times the cancers are ignored for many months. We have had breast cancer patients who are having an increasing lump for 2 years or 3 years, and finally it has reached the stage of fungation or bleeding, and finally the patients are presented by the time with the disease already metastatic. So the treatment is at par that of US, that of the West, that of China. But unfortunately, there is a delayed presentation in the OPD, and there is a delay, sort of an epidemiological change. Very young patients, high grade tumors, aggressive tumors in India. Next slide, please. What are the risk factors for breast cancer and advanced age? So age is the biggest risk factor for any cancer, and advanced age is one risk factor. First degree relative with breast cancer, very important. So suppose the mother having breast cancer, the daughters have to be counseled about screening and other things from 40 years onwards. If there is a genetic predisposition, BRCA1 and BRCA2 genes, with Angelina Jolie undergoing a mastectomy to prevent breast cancer because of this genetic mutations, people are aware that there are genetic mutations which can lead to breast cancer, ovarian cancer, and a family history needs to be taken whenever the breast cancer patient presents the OPD. Early menarche, late menopause, nulliparity, first full-term pregnancy after the age of 30. Again, in urban environment, the first age of first pregnancy is definitely delayed. It corresponds to higher education, jobs, etc. So definitely age of first full-term pregnancy after 30, 35. Personal history of breast, ovarian, endometrial cancer, obesity, very important. So this is something which can be modified. Postmenopausal breast cancer is associated with obesity, high breast tissue density, long-term estrogen replacement, and prior irradiation. In this, what is important to note is there are certain non-modifiable factors like menarche, menopause, advanced age, or a family history. But obesity is one of those factors which is potentially modifiable. And another protective thing for breast cancer is a prolonged breastfeeding. So that has protective effect on breast cancer. So definitely these are the brief risk factors for breast cancer in women. Next slide, please. So what are the signs and symptoms and what is the history taking? I know the topic is about management, but we need to just go through the basics again. If there is a new lump or mass, that is the most common presentation. If you have a breast or nipple pain, that can also be a symptom of breast cancer. It can be a symptom of mastitis or cystic disease of the breast, but pain sometimes, yes. But usually breast cancer is a painless progressive lump, especially in a postmenopausal lady. If she's presenting with a breast lump, the probability of breast cancer is very high. Swelling in all or part of the breast, even if no distinct lump is felt. So basically these inflammatory breast cancer, no distinct lump is felt. You are just having an induration of the skin, but that can present as just an induration of the skin, no lump per se. Skin irritation or dimpling, nipple retraction. So you are seeing in the images below. So edema of the skin, skin dimpling, abnormal contour or a nipple retraction, nipple is turning inwards. Changes of the skin of the breast or the nipple, that is called Paget's disease. And nipple discharge, hemorrhagic discharge from the nipple can actually herald breast cancer. Next slide, please. The breast examination should be done in sitting position, leaning forward position, and lying down position, 3 different positions. We have to palpate both the breast irrespective of where the symptoms are present. We have to palpate the axillary nodes and the neck nodes because the first area of first metastasis, lymph nodal metastasis, is the axilla, and you can have a supraclavicular or a cervical lymphadenopathy also, and chest and abdominal examination because breast cancer can metastasize to the lungs, can metastasize to the liver. So basically this will complete the examination. Palpation of the glandular area is done with the palm of the hand. Palpation of the areola, compression of the nipple is all a part of examination, and it has to be done in 3 different positions. Next slide, please. So some images. So this is Paget's disease, which I had mentioned. So you are having the skin change over the nipple. The nipple is actually not visible. It is being by this eczematous scaly crusted lesion. and you are having this on the right side a peau d'orange appearance, so like a or skin of an orange, because of lymphatic metastasis of the breast cancer, and this is classically seen in breast cancer. So if you have certain these changes, your index of suspicion goes very high. Next slide, please. Stages of breast cancer, not going into detail. Stage 1 is a small tumor. Stage 2 is a bigger tumor, more than 2 centimeter. Stage 3, usually you have involvement of the lymph nodes, usually of the axilla. And stage 4 is metastatic breast cancer. And the common sites of breast cancer metastasis are the lungs, liver, bone, and especially in HER2 positive breast cancer and triple negative breast cancer, the brain. Next slide, please. What are the investigations? So whenever you have a breast lump, you can consider a bilateral mammogram. Then the next step is a true cut or a core needle biopsy of the breast lump, and which may be ultrasound guided. We may use ultrasound or image guidance, or you can do it if the lump is quite big, blindly also. What about the staging? And there is a misconception that biopsy might lead to cancer spread, and that the patient has to be reassured that that is not the case. And in almost all the cases of breast cancer, unless and until the lump is extremely small, we do proceed with a biopsy. We don't plan a breast surgery blindly, because malignancy versus no malignancy, the surgical principles are totally different. I'll come to that later. And you are seeing on the image that a core needle is inserted and multiple cores are taken for histopathological examination. As I said earlier, lung metastasis may be seen. So chest X-ray and ultrasound for assessing the liver, a bone scan, etc. depends on the symptoms, whether the patient is having cough, whether the patient is having abdominal pain, whether the patient is having bone pain. But in early breast cancer, we usually don't do very like exotic radiological investigations. It is all clinical. We may do a basic chest X-ray. In locally advanced breast cancer, if there is a significant axillary lymph node involvement, then we proceed with a CECT chest and abdomen and a bone scan, or nowadays, most of them with a significant axillary lymph nodal involvement undergo a whole body PET-CT to rule out metastatic disease. Next slide, please. Mammography procedure, everyone knows, but basically the breast is compressed between the two plates of the X-ray, and you have two views, craniocaudal view and a mediolateral view. And cancer is visible, and there are certain things which herald cancer. Next slide, please. For example, in this image, on the left side, what you are seeing is microcalcification. Those small whitish specks which are there, they might herald breast cancer, or you might have an irregular border and a lump on the right side, which is heralding a sort of breast cancer. And that can lead us to two things that can actually tell us the breast cancer is there or no in the lump. And mammography can also tell us whether the cancer is multicentric. So basically, the breast lump may be felt in one area, suppose the upper and outer quadrant, but inside in the mammogram, there might be other microcalcifications in the lower quadrants also. There might be something retroareolar. Why that is important is, if there are multiple quadrants of the breast involved, then the surgical procedure usually is a complete mastectomy, not a breast conservation surgery only, because you have to address the other abnormal sites also. Next slide, please. So when we do the biopsy, as I told you, biopsy is mandatory in almost all the cases, unless and until the lump is very small, in which case we consider doing an FNAC or an intraoperative frozen section. Once we do a biopsy, this test is also important. So a hormone receptor and HER2 test. This is performed by immunohistochemistry, IHC. That is essentially a technique, a pathological technique, which looks at the expression of various proteins on the tissue. So what is ER? Estrogen receptor. PR is progesterone receptor, and HER2 neu is another protein, tumor epidermal receptor, which can produce aggressive tumors. So all these three things are tested. So if we look at the slide on the top, we are seeing that you are seeing those brown pigmented spots. What is it showing is how many cells are actually positive. So that is called a proportion of cells which is positive. And lower down, you are seeing that you are having colors ranging from light brown to a very dark brown. That is showing intensity of staining. So these two factors taken together are called ALRED scoring. And this is used for estrogen and progesterone receptor reporting. So very strongly positive, weakly positive, intermediate, how many percentage of cells are positive, all this is taken into consideration. The second thing is HER2, again, it's somewhat similar to this. And if at all HER2 is intermediate or equivocal, so HER2 is reported as negative, that is 1 plus or 0 on the IHC. So a very minimal amount of protein is there. 2 is equivocal, so it is not positive, not negative. 3 is considered positive. So suppose you have HER2 nu as 2 plus on IHC, HER2 nu 2 plus. A fluorescent in situ hybridization is very important, which will check for HER2 amplification. What does amplification mean? You have extra copies of the HER2 gene, which are leading to increased aggressiveness of the tumor. And you are seeing in the left, in the lowermost box, you are seeing a FISH test for HER2. Next slide, please. So HER2, ERPR, HER2 nu determines the treatment. That is why it is very important. It determines the treatment because if you have a hormone receptor positive breast cancer, hormonal therapy has to be given, irrespective of whatever is the stage of the tumor. If you have a HER2 positive breast cancer and the tumor is 1 centimeter or more, definitely you would have to give HER2 directed therapy. And if you have a triple negative breast cancer, neither hormonal therapy works nor HER2 directed therapy works. You have to consider giving chemotherapy if the tumor is 0.5 centimeter or more. And triple negative breast cancer is considered to be the most aggressive variety of breast cancer. So ERPR HER2 nu determines the treatment. Next slide, please. Also, it may determine the outcome of the disease, the behavior of the disease. So you see triple negative breast cancer, they have increased chance of metastasizing to the viscera, to the lungs, to the brain, as I had mentioned earlier. And you have hormone receptor breast cancers, which have more predilection for bone metastasis, or maybe like indolent bone metastasis. The secondly, what is very important is HER2 positive breast cancers, triple negative breast cancers also have increased chance of brain metastasis. Also, they have increased chance of early metastasis. So in HER2 positive disease and triple negative breast cancer, the 5 years after the breast cancer is treated are very crucial. They don't usually have a very late relapse. Whatever relapses are there are within the first 5 years of treatment. But in hormone positive breast cancer, you can have a very late relapse also, beyond 10, beyond 15 years also. So a thorough follow-up is taken. And just because there is a new symptom after 10 years, a hormone positive breast cancer may be the cause. You cannot say that that is done with, that has cured. No, hormone positive breast cancers may relapse later on also. Right.
तो उसने क्या किया, नवरत ओम जाने दे, अभी तुम हमको भेज सबको, मैं भेजता हूँ, तो उसको भेजा. यस सर.
Lord sir.
Yeah. Next slide, please. Yeah. So now we come to localized or locally advanced or early breast cancer. So any cancer confined to the breast and the axillary lymph nodes is considered to be a locally advanced. So axillary lymph nodal involvement usually is considered to be a locally advanced tumor. Any tumor which is very large in size or involving the skin, again, it is considered to be a locally advanced breast cancer. And in early breast cancer, there is a discrete lump, no skin involvement, probably no lymph nodal involvement. But the principles of surgery are two. So essentially, you have a modified radical mastectomy, which includes the removal of the breast, the skin over the breast, and also the axillary lymph node dissection, and a breast conservation surgery or a lumpectomy, which involves the removal of the breast tissue, affected breast tissue, and involvement of the removal of the lymph nodes. Sometimes in early breast cancer, we do something called as a sentinel lymph nodal biopsy. Those surgeons do. So a dye is injected into the tumor, and the first lymph node which takes up the dye, that is the sentinel node, and that is the only lymph node which is dissected out to see whether the cancer is spreading to the lymph node or no. If at all that is positive, then you completely dissect out the axilla. So this is another technique in the early breast cancer. Next slide, please. Axilla is always addressed in the breast. So suppose you have a patient who has been operated somewhere in interiors or somewhere in a village setting, and you have a pathological report which is saying that the breast is containing tumor, and the pathological report is not showing any axillary lymph nodes, you have to proceed with the axillary lymph nodal dissection in all the cases, because of the simple reason that irrespective of the pathology, irrespective of no lymph nodes in the axilla, there have to be a lymph node in the axilla. So you cannot have an oncological breast surgery without addressing the axilla. So if you have a patient who has come with only a simple mastectomy, no modified radical mastectomy, consider referring to an oncosurgeon and addressing the axilla, because you might be leaving disease behind, which might lead to further problems. Second point is breast conservation treatment. So only a lumpectomy is always followed by radiation. So whenever you counsel the patient, you have to you have to talk about the budget for both surgery and radiation at least, because you cannot just say that khatam ho gaya, that or hormonal treatment or something like that. So you have to talk about radiation, you have to talk about the surgery. What are the complications of breast surgery? Upper arm pain, lymphedema, infection are potential complications. And what are the contraindications to a lumpectomy? So pregnancy, persistent positive margins. So you try to take out only the lump, but again and again, there is a residual disease left behind. Large tumor in a small breast, again, it's difficult to sort of do a breast conservation surgery, and history of prior irradiation. With plastic surgery and with flaps, etc., nowadays, there is a lot of breast reconstruction also being done. So even after mastectomy, we may consider plastic reconstruction of the breast. So breast conservation surgery is always preferred. Can someone mute Can someone mute the participants?
अनिल आवाड साहेब, व्हॉल्यूम चालू आहे तुमचा, बंद करा प्लीज. Everyone should mute.
Yeah. So the thing is that, so basically plastic reconstruction also is an option even after we do mastectomy. Next slide, please. So what are the chemotherapy principles? It can be given before chemotherapy. So suppose you have a large tumor which is involving the breast, involving the lymph nodes. There is a skin involvement. There is maybe a cervical lymph nodal involvement. Definitely, it can be given before the surgery. It is called neoadjuvant chemotherapy. And there is an important concept called pathological complete response, which I'll talk about later. The chemotherapy can be given after surgery. It is called adjuvant chemotherapy. The drugs used are anthracycline, cyclophosphamide, and taxanes. I'll not go into details, but essentially it involves approximately 4 to 5 months of treatment, the chemotherapy, right? Cardiac function has to be assessed. So the 2D echo is mandatory before initiating any anthracycline-based chemotherapy. And trastuzumab is used. It is an anti-HER2 antibody in case the tumor is HER2 positive. Up to 1 year of treatment includes trastuzumab. To be very clear, not all breast cancer patients require chemotherapy. I'll be very clear here. There are some breast cancer patients who have a very indolent disease, hormone receptor positive disease, no lymph nodal involvement. They only are treated with hormonal treatment. But if the tumor is not having hormone positive, if the tumor is HER2 positive or triple negative breast cancer, most of the patients require chemotherapy. Again, in young people, even if they are hormone receptor positive, so I gave one example of a patient, very young patient, 23-year-old. So she will probably require chemotherapy irrespective of her hormone receptor positivity, because cancer in young is pretty aggressive and we tend to give chemotherapy in such patients. But not all patients will require chemotherapy. Next slide, please. So what are the absolute contraindications and relative contraindications, absolute and relative indications of neoadjuvant therapy? So when should chemotherapy be the first choice and then the surgery should come? So if a patient has got an inflammatory breast cancer, which I told is an aggressive variety, no discrete lump, cancer cells in the dermal lymphatics, or if the patient has inoperable locally advanced breast cancer. So if the patient is, if the surgery is not expected to remove the tumor completely, you can consider neoadjuvant, you should consider neoadjuvant therapy. And neoadjuvant chemotherapy can be considered in a large tumor with axillary lymph nodal involvement. Neoadjuvant chemotherapy can be considered if the tumor is large, but you want the patient to have a breast conservation surgery, so you want to shrink the tumor. And you can consider in any patient who is a candidate for adjuvant therapy and has a palpable tumor, especially in certain settings like a triple negative disease, where the tumor can significantly respond to a chemotherapy and is downstage prior to a surgery. Next slide, please. What is pathological complete response? So suppose in some patients we give chemotherapy before the surgery and we go ahead with surgery. So we take out the lump or take out the entire breast and we address the axilla, and there is no tumor in that post-operative pathological specimen, that is called a pathological complete response. That means your chemotherapy has melted the tumor completely, and it is associated. There is still controversy on this, but pathological complete response may suggest an improved overall survival in certain patients. The second point is, there are certain trials coming up in which you give chemotherapy earlier, you do a surgery, and in that there is still some tumor remaining. You can give other treatment after the surgery to counteract that tumor remaining and to counteract the poor prognosis. So something called as a post-neoadjuvant residual disease treatment. Again, this is an evolving concept, but there is a concept called pathological complete response, which might have and patients might have a better outcome if they achieve this. Next slide, please. What are the side effects? Anthracyclines cause cardiotoxicity. 2D echo has to be done prior to starting. Alopecia, hair loss, nausea, vomiting, especially with anthracycline. Febrile neutropenia. Docetaxel is notorious for causing early neutropenia. So it is given with growth factors like granulocyte colony stimulating growth factors, filgrastim. Neuropathy, taxanes may cause it. And there are recent trends like scalp cooling for alopecia, cold stockings for preventing neuropathy. So basically the side effect management has also evolved with time. Next slide, please. What is targeted therapy or HER2 directed therapy? And in this, there are multiple drugs, but I'll just talk about trastuzumab today. HER2 is a protein and it's a growth factor receptor, basically, which confers aggressiveness to the breast cancer. And like I said, it is determined by IHC, immunohistochemistry. 0 and 1 is negative, 2 is equivocal, 3 is positive. If at all the report is 2, you have to perform a FISH to confirm whether it is positive or negative. If it is positive, that means the HER2 is amplified. There are extra copies of the HER2 gene. And trastuzumab basically inhibits the HER2 mediated signaling in HER2 positive tumor. It prevents the HER2 activation by blocking the extracellular domain cleavage and activates antibody dependent cellular cytotoxicity. So basically some immune response also. And essentially, if we give trastuzumab in a HER2 positive breast cancer, overall the risk of recurrence is reduced by 30 to 40%. So this is an integral component of treatment. The duration of trastuzumab usually is 1 year of treatment, and it constitutes around 17 doses of treatment. Once upon a time, when generics were not available, the cost of 1 vial of trastuzumab was around 50 to 60,000. Now it has come down to 15 to 20,000. So it has become much affordable. Also, there are trials, there are certain studies which say that 1 year of treatment is not required. We may consider a 6 months of treatment in certain individuals also. Next slide, please. So what about the hormonal treatment? And that is, as I told you, any patient with hormone receptor positive disease, we have to give a hormonal treatment. So hormone receptor positive matlab ER positive is 1% of tumor cells are expressing estrogen receptor, 1% or more, and PR is 1% or more are expressing estrogen receptor. 1 to 9% is considered very weak hormonal positive, and 10% or more, we are very happy that it is a substantial hormonal positivity. So what is tamoxifen? So tamoxifen, again, it blocks the action of estrogen at the receptor level. And tamoxifen is one hormonal agent which we have been using for a long time, and it has antagonistic action at the breast cancer tissue, but it has agonistic action in the endometrium. So tamoxifen has issues like endometrial hyperplasia or endometrial cancer in 1% of patients, thromboembolism, but it does not have risk of osteoporosis. There are another agents called aromatase inhibitors, which we use exclusively in postmenopausal breast cancer. So what is aromatase? So you are seeing at the top end of the slide, aromatase is an enzyme which is converting the androgen, which are secreted by the adrenal glands or the fat tissue, to estrogens. So you are having androgen being converted to estrogen because of aromatase. And this is important in patients who are actually menopausal, because ovary is not producing your hormones. It has already stopped working. But in postmenopausal ladies, aromatase enzyme and peripheral production of estrogen may play a role in increasing the breast cancer risk as well as increasing the breast cancer recurrence risk. So you use medicine which block this aromatase enzyme, which block this conversion of testosterone or androstenedione to estrogens, and you can give a aromatase inhibitor in the postmenopausal setting. In the premenopausal setting, there is no use because your ovary is anyway producing a lot of hormones. It is not used in premenopausal setting, but in a postmenopausal setting, aromatase inhibitors are used in place of tamoxifen. So both are not used, either one is used. Another thing is, I told obesity is a risk factor for postmenopausal breast cancer. Why? Because more the fat, more is this conversion of testosterone or androstenedione to estrogen precursor. So that is why obesity is one controllable factor for postmenopausal breast cancer. What are the adverse events with aromatase inhibitor? So they don't cause much of endometrial effects or thromboembolism, but the major adverse event is osteoporosis. Okay, so bone DEXA scan, bone densitometry may be done before starting aromatase inhibitor. Next slide, please. It is indicated in all hormonal positive breast cancer. So adjuvant endocrine therapy, if there is hormone receptor positive, either tamoxifen or aromatase inhibitor are indicated after the surgery or radiation or both of them. And whether we use chemotherapy or no, as I told you, we don't use it in everyone. What are the drugs used? Tamoxifen, we have already mentioned, aromatase inhibitor, anastrozole, letrozole, exemestane. 3 drugs, 3 examples, either one we can use. It is only for postmenopausal women. Please remember, in premenopausal ladies, only tamoxifen is used. Duration of therapy, at least 5 years of hormonal therapy is recommended. And when do we start it? Usually starts after the completion of chemo and with radiation, if both or either is needed. So after chemo, we can start after chemo with radiation, or after radiation also sometimes, but but basically you don't give hormonal therapy with chemo usually. Next slide, please. So there are certain evolving concepts that, as I told you, not everyone requires hormonal treatment. So nowadays, in certain hormone receptor positive patients, we do molecular testing. So this is one test which is US based called Oncotype DX, which studies all these genes and tells us whether we have to give chemotherapy, whether the tumor is high risk, or whether we can get away with hormonal therapy. Unfortunately, the cost of this is approximately 3 lakhs. But even in India, tests are coming up like Can Assist, which at around 70,000 rupees can tell us this risk of recurrence and tell us whether a particular patient requires additional chemotherapy or no. Next slide, please. If the patient does not have enough funds, and I practice in IR hospital also, so I have to cater to everyone. There are certain online tools, certain online apps like this Adjuvant Online, which is currently not working. There is something called as UK Predict, which is working, and in which you can put the parameters like the tumor size, lymph node positive, negative, and predict whether chemotherapy will help a particular patient or no, and take a decision accordingly. Next slide, please. What is the principle of radiation treatment? It is always given after lumpectomy. Duration of radiation is approximately 3 weeks, but nowadays there are trials which suggest that radiation may be completed in 5 days also. So 1 week, especially in COVID situation, to go to a radiation center again and again for 3 weeks is tricky. So sometimes there are trials which suggest a 1 week of treatment may also be done. In modified radical mastectomy, so you remove the complete breast. If there is a significant axillary nodal involvement, definitely we consider radiation, or if there is a large tumor more than 5 centimeter, we consider radiation. Usually, in case the patient is receiving chemotherapy, it is given after chemotherapy. Radiation and chemo again are not given together. And hormonal therapy or trastuzumab, the targeted therapy, may be given together with radiation also. There is no additional side effect. Next slide, please. So metastatic disease is a whole new story, and perhaps we'll have a separate seminar for a metastatic disease down the line someday. If the patient is having metastasis to say lung or liver, either at diagnosis or the cancer has come back, like I said, after 2 years, 3 years, or maybe 10 years, we do a PET scan basically that will tell us where all the disease is present. We can also do a CT and a bone scan, that is also fine, but usually we do a PET scan. If the patient is HER2 positive, triple negative breast cancer, etc., presents with headache, we also do an MRI brain. As I told, there is an increased chance of brain metastasis. If there is hormone receptor positive disease, if the patient is only having visceral crisis, like the patient is having severe lung mets causing shortness of breath, or the patient is having multiple liver mets which is causing liver dysfunction, only in those patients we give chemotherapy. Otherwise, even in metastatic disease, we treat with oral pills, some hormonal injections. We don't give chemotherapy in all if the patient is hormone positive disease. What are the newer drugs? There is an injection called fulvestrant. This is a selective estrogen receptor downregulator. And there are newer drugs called palbociclib and ribociclib. They are the CDK4/6 inhibitors, which work on the cell cycle, and they are used in metastatic breast cancer in combination with your aromatase inhibitor like letrozole, or in combination with this injection called fulvestrant. HER2 positive breast cancer, if it is metastatic, you give trastuzumab and you give chemotherapy. If it is triple negative, there is chemotherapy only is the option, and there is upcoming role of immunotherapy. And you also have supportive care. So suppose you have a bone met, you can irradiate the tumor. If you have brain metastasis, you can give radiation to the brain metastasis. And you also give, if there are bone mets, zoledonic acid bisphosphonates every monthly or every 3 monthly, depending on the situation in the metastatic disease setting. Next slide, please. So to recapitulate, Globocan 2018, breast cancer, most common cancer in India, urban predominant, late presentation, advanced stage as compared to West. History and physical examination important. Risk factors should include family history because of the genetic issues which are at play. Bilateral mammogram and core-needle biopsy are the basic investigations. And people are afraid of biopsy. Please tell them that this is not an issue. Please proceed with biopsy. It's an important workup in breast cancer, suspected breast cancer. Next slide, please. ERPR HER2 testing is mandatory. Surgery, MRM and breast conservation surgery, even after MRM, plastic reconstruction, etc. may be done. Chemotherapy not required for everyone. Okay, not required for everyone. Adjuvant, post-surgery, neoadjuvant, pre-surgery. We talked about the concept of pathological CR if we give pre-surgery. Hormonal treatment, if at all the patient is hormone receptor positive, in all cases we give hormonal treatment for a minimum of 5 years. If the patient is HER2 positive, HER2 is determined by IHC. If it is 2+, we do FISH. Trastuzumab is given for approximately 1 year. Treatment of metastatic breast cancer depends on the ERPR HER2 status and on symptoms. Next slide, please. Thank you. I have come to the end of my presentation.
Sir, excellent, absolutely excellent presentation. Short, sweet, and a great take-home message for all of us. Thank you so much, sir.
Thank you. Hi, Avya.
आवाज गिरा है. Who is talking?
Yeah. 1 minute. 1 minute.
Oh, Dr. Usha.
Yeah. So there is one question from the audience. In the investigation, what is the mammography protocol? According to the age, is sonomammography versus X-ray mammography, role of MRI in diagnosis?
So a very, very, very good question. So number one is the sensitivity of mammogram or mammography. Mammography and mammogram is essentially the same. There is another question in the chat box which is asked about the difference. Sensitivity of mammogram increases with age. So basically, increased fat content and decreased glandular content will increase the sensitivity of mammogram. So as there is aging, the fat content is increasing and the reproductive cycle comes to an end. So beyond 40 years of age, mammography is sensitive, and most of the international screening protocols include mammography beyond 40 years of age. That is number one. But in a younger patient, usually we combine the two, a sonogram as well as a mammogram, and a sonomammogram is performed to better delineate the structure of the tumor or the tissue or the architecture of the breast. So younger patients, sonomammogram. Beyond 40, only mammogram. But even beyond 40, depending on a particular clinical situation, sonomammogram could be offered. There is nothing against it. As far as the MRI of the breast goes, MRI of the breast. So specific indication for MRI of the breast are certain things like lobular breast cancer. So if your biopsy is showing lobular breast cancer, you can have a multicentric disease. You can have an opposite side disease. And definitely in those situations, you do an MRI of the breast. That is number one. Number two, in certain cases, like you have an axillary lymph node which is showing breast cancer, and there is nothing palpable and nothing obvious on the mammogram. So a breast primary is suspected, but mammography is not able to provide a complete information. We do an MRI. That is the second. MRI is also done for screening in young patients beyond 25 years of age, if they have a genetic problem like BRCA1, BRCA2. So for young patients, 25-year-olds, you do a yearly MRI till 40, then you do a yearly sonomammogram or mammogram. So these are the settings in which we do an MRI of the breast. It is a very important investigation, but it is not done routinely for all patients.
Sir, can I ask one more question?
Yeah, please.
What about the role of HPV vaccine?
So we have
At what age it should be given? Till what age it should be given?
So we have shifted from breast to cervix cancer, and that's fine. That's fine. That's not a problem. So this is the HPV is only for the cervix. So the point is that's fine. So, but basically, ma'am, the age should be 10 to 14 years of age. The logic is that it was first initiated in the US, and the age of first sexual contact, because HPV spreads by sexual contact, is much earlier in the US as compared to India. So ideally in the US, they give from 9 years onwards, in fact. And in India, you ideally have to give in the adolescent age group. And up to 26 years of age, essentially you can consider HPV vaccination, absolutely. But it makes sense to vaccinate early because of overall westernization of the entire situation.
Okay, nowadays the children are coming more in the clinic for this vaccine.
Yeah, absolutely. I think it is justified.
Okay, thank you so much, Dr. Bansal.
9 to 14, you can like as young as 9 or 10 years to 14 years is the sort of sweet spot, but it can be even considered beyond that also.
Rohit Pai's lecture is flooded with a zest and enthusiasm. Really appreciate it. Great.
Thank you, sir.
Thank you, sir.
Thank you so much, Dr. Rohit Pai, for giving an excellent information about the breast cancer. Thank you so much. Now we'll move to the next speaker. The next speaker is Dr. Avya Bansal. I request IMA CGP Secretary, Sub-Faculty Dr. Kajal Ahuja to introduce the speaker. Over to Dr. Kajal Ahuja.
Kajal Ahuja, madam, good morning.
Good morning.
Nice to see you in a pleasant mood always.
Dr. Avya Bansal is a consultant chest physician attached to Bombay Hospital and Medical Research Center, Mumbai. He has to his credit MBBS, MD, DNB, Respiratory Medicine, and FAPSR degrees. He has a brilliant academic career. He is the youngest recipient of fellowship of the Asian Pacific Society of Respirology. He has several publications in national and international index journals. He has presented papers at the national and international platform. He is a member of Indian Chest Society, American College of Chest Physicians. Today he'll be speaking on right, antibiotics right. Over to Dr. Avya Bansal.
Good morning. Thank you, IMA, for this wonderful opportunity.
Good morning, sir.
Good morning. Good morning. Can I share my screen now?
Yes, yes.
I don't think I have that option yet.
So it will be there down. Share screen, green one. Yeah.
So good morning. Without wasting further time on a pleasant Sunday morning, let us come to the topic, right, antibiotic right. That's the war against resistance. Now we'll be covering the antimicrobial resistance, challenges and initiatives, steps of rational antibiotic use, surveillance of antimicrobial resistance, antimicrobial recipients and shared decision making, the AMR benchmark 2020, the AMR guidelines, which is the GSK initiative, and we'll summarize the entire thing. Now, as we can see, with the evolution of time, bugs have also evolved. We had a masterpiece telephone back in the 1900s and early 2000s, which has come to a cordless mobile phone and coming to a touchscreen Apple iPhones. Now, Paul Ehrlich very famously once said that drug resistance follows the drug like a faithful shadow, and there's no escaping it. If we come to the antimicrobial resistance pattern and the antibiotic usage in India from 20,000 to 2015, we've seen that broad-spectrum penicillins, fluoroquinolones, trimethoprim, cephalosporins, and macrolides have been the prime usage. Now, from 2000, we can see that the light green is the cephalosporins. It has gradually shown a steady rise, whereas our conventional antibiotics such as trimethoprim, which is a part of the Bactrim DS, has been constantly used. Your macrolides, azithromycin, clarithromycin have also remained the same. Penicillins initially showed a flurry and then have gradually remained the same. Fluoroquinones came in vogue in the early 2010s and now have shown a gradual decline owing to the rapid development of resistance. Whereas the cephalosporins have been gradually increased. The usage of cephalosporin has gradually increased. The 30% rule, what is the 30% rule? That if all 30% of hospitalized patients at any point of time receive antibiotics, over 30% of antibiotics are overly prescribed, 30% of all surgical prophylaxis is inappropriate, and 30% of hospital pharmacy costs are due to antimicrobial usage. So the rule of 30% hospitalized patients require and don't require antibiotics, inappropriate use, overuse during surgeries, and 30% of entire cost of the hospitalization is due to the antibiotics. Now, a carbon footprint and an antibiotic footprint are very, very similar. They do leave a mark, and this often takes years and years and years of either medical practice to come out with a novel bug defeating antibiotic. The same way the carbon footprint takes years and years to leave our environment. Now, what are the 10 threats to global health? This was way back in 2019. If we have a 2020, 21, and 22 consensus, COVID-19 pneumonia is going to be number one. However, let's stick to the 2019 data, which says that air pollution, climate change, non-communicable diseases, global influenza pandemic, vulnerable and fragile settings, antimicrobial resistance, Ebola, vaccine hesitancy, dengue, HIV, and weak primary healthcare. So even if we add COVID-19 as number one, the 2020 and 2021 global health data has not yet been out. The antimicrobial resistance is still going to play a number 5 and a number 6 role in these settings as well. Now, what is the cost of your antimicrobial resistance? Approximately 10 million. This we can see that 10 million AMR in 2015. When we compare tetanus, road traffic accident, measles, diarrhea, diabetes, cholera, cancer, the deaths are going to be 10 million in antimicrobial resistance in 2050, which is the maximum compared to any of this, even defeating cancer, which is why the judicious use of antibiotics is so very important in today's day and age. The Perfect Storm, a very famous George Clooney movie, had come out, and it fits perfectly when we come to the antimicrobial resistance and antibiotic use pattern. We've seen that the 1980s, 84, 85, 89, the gradual thing, we've seen that the companies researching antibiotics and the new antibiotic production has gradually reduced owing to the formation of drug-resistant pathogen, tuberculosis, staphylococcus, ESBLs, gram-negative organisms. Now, what is the important step of rational use of an antibiotic? Firstly, it's accurate diagnosis that the antibiotic is actually required. Prevent empirical use of antibiotics, such as in COVID-19. The widespread of antibiotics has actually increased the resistance in the basic novel over-the-counter antibiotics. Know your bugs, which are your common community-acquired bugs. Use the appropriate antibiotic of choice. In case of community-acquired pneumonia, in an OPD setting, maybe an amoxiclav plus an macrolide could be the drug of choice as recommended by the CDC and WHO. De-escalate and modify antibiotics in case there is an improvement in the patient. Avoid antibiotics when there is no indication. Reduce the therapy duration to optimum, maybe 5 to 7 days on OPD basis and 7 to 10 in inpatient. And optimize the PK/PKD, pharmacokinetics and pharmacodynamics of the antibiotics. An accurate clinical diagnosis of prime importance. Firstly, is it a bacterial infection? How likely is that the patient has infection? Is it a non-infection mimic? There's an alternate diagnosis. And have you taken appropriate cultures such as a blood bacteria, urine, and sputum culture? Now, acute bacterial rhinosinusitis. Now, accurate diagnosis to prevent antibiotic resistance. It's very important to distinguish between a viral sinusitis and a bacterial sinusitis. Now, the IDSA 2012 guidelines on ABRS, persistent and non-improving disease of more than 10 days, severe symptoms of high fever, that's 102 and above, with a purulent nasal discharge, this is very important, of yellow or green sputum and discharge from the nose, facial pain lasting for about 3 to 4 days, and worsening of symptoms of double sickening. These are the indications for an antibiotic use in acute rhinosinusitis clinical picture. Now, limit the empirical antibiotic use, start smart, have a focused therapy, and plan the duration of therapy. This is very, very important. Now, coming to the community-acquired pneumonia, I've already said about this. The ICMR 2019 guidelines tell us that the OPD patients with comorbidities, amoxicillin becomes the drug of choice with an optimum duration of therapy for 5 to 7 days. In case of penicillin resistance, and azithromycin alternate can be tried. In outpatient use of antibiotics more than 3 months in the past, amoxicillin plus an azithroclarithrol or a doxycycline, that is to cover an atypical. An alternate can be your cephalosporin cefuroxime. And an inpatient in a non-ICU setting, a ceftriaxone plus a macrolide or doxycycline coverage, or a cefotaxime plus amoxicillin plus macrolide coverage should be given for at least 5 days, provided the patients don't have a chronic liver, lung, heart disease, diabetic malignancy, or immunosuppressed disease. In these cases, a culture requirement becomes of utmost importance. Now, please know your bugs, a clinical syndrome, what is the source of infection, the possible pathogens, and the resistance pattern in your hospital. Now, every hospital and ICU setting is going to have their own antibiotic resistance pattern and their own bugs. Now, what is the GSK survey of antimicrobial resistance? It was launched 2002. There were 35 countries participating. And the pathogens tested were community-acquired respiratory tract infections, typically your staph, pneumonia, and your influenza. And susceptibility testing method was a CLSI, using the pharmacodynamic and pharmacokinetic breakpoints. Now, we've seen that cephalosporin in the CLSI, cefuroxime was 75%, followed by cefpoxime, which is 67%. The penicillins oral were about 49%. The macrolides clarithrol, azithro, erythro. The quinolones being oflox and levofloxacin. And the others were SHT, the sulfamethoxazole trimethoxypyrin. We have seen that the UCAS and the PKPD showed that the cefuroximes did far better as compared to other drugs in being sensitive to the Streptococcus pneumonia isolates. Coming to the influenza, again, the cephalosporins out-defeated penicillins, macrolides, and quinolones with a 90 to 80 ratio, which is a significant p-value, with cefixime and cefuroxime being at the top. When we come to the other Mycoplasma catarrhalis, again, cefuroxime was significantly superior to your penicillins and quinolones, as with Streptococcus pyogenes. Now, coming to choosing the appropriate antibiotic, the dose, route, and duration of the treatment, the antibiotic spectrum, the diseases which it covers, gram-positive, negative, atypical. What is the tissue penetration? You can't give a certain antibiotic for a UTI and you can't give a certain antibiotic for a lung infection. The penetration has to be ideally studied for both these antibiotic classes. And what is the resistant pattern in your particular setting, in your particular ICU and your patient population? In the American Academy of Pediatrics and the American Academy of Family Physicians on the clinical practice guidelines in AOM, the recommended first line of treatment is your amoxicillin, amoxicillin clavulanic acid, and amoxicillin clavulanic acid may be administered if the patient was given 30 days prior and has conjunctivitis, or if a cover of Haemophilus and Moraxella required. So the first line of treatment would be your amoxicillin in your acute otitis media. Now, the rationale for achieving optimal antibacterial efficacy. Now, during AOM, that is your acute otitis media, the most pathogenic bacteria is seen in the extracellular middle ear fluid, where beta-lactam antibiotics also concentrate. The other antibiotics such as macrolides, azithromycin, are found mainly within the cells. Therefore, the effective eradication of pathogens by amoxicillin is the result of adequate penetration into the middle ear fluid. We can see that the beta-lactam is present in the middle ear, which is formulated by your triangles, whereas your macrolides is within the cells. The pathogens are here. The pathogens are present in the middle ear fluid, which is why we need an antibiotic which acts in the middle ear fluid rather than acting within the cell. Now, when do we de-escalate, modify? Firstly, we have a broad spectrum, which is a narrow spectrum antibiotic. We have a combination therapy versus a monotherapy, an IV versus an oral, and antibiotics versus discontinuation of antibiotics. Now, stop antibiotics in viral respiratory syndromes. This has become the rampant use of antibiotics in our current COVID-19 setup. It is not required, overused, and will eventually lead to excessive resistance development in the novel nascent population. In non-infectious cardiopulmonary syndromes, an acute exacerbation of asthma, acute exacerbation of COPD, a cardiogenic failure, these do not require antibiotics. Subcutaneous abscesses and stasis dermatitis, asymptomatic bacteria, where you've got limited pus cells and a culture keeps remaining positive for weeks and years to come, and a microbial colonization which is not affecting the patient in any way. The optimal assessment of an acute otitis media in the ICMR guidelines if the patient is having a severe AOM, which is less than 24 years of age with a bilateral disease and an autouria, initiate antibiotics. If the patient is above 2 years of age, non-severe disease, a unilateral disease, wait for 48 hours and then see if the patient is responding to a self-limiting disease or worsening. Reduce the duration of antibiotic treatment to minimum possible duration and stop and plan a date. For example, in a community-acquired pneumonia, plan for 5 to 7 days and do not overprescribe for 10 days, 14 days, and 21 days. An upper respiratory tract syndrome, a URTI, bacterial sinusitis, the drug of choice still remains an amoxicillin, followed by a ceftriaxone and cefpodoxime in adults. In case there is a penicillin allergy, you can consider doxycycline and macrolides, and the duration of treatment in adults is 5 to 7 days, followed by 10 to 14 days in children. We optimize the PK/PD parameters. Age of the patient is important, the comorbid conditions, the loading dose, therapeutic drug monitoring. Often we have seen that a particular sensitive antibiotic is not achieving an adequate result in the patient. Check the therapeutic drug levels. For example, in a viral infection, when you're using voriconazole or tubercular medication, check the drug monitors in this patient population. Maybe the drug is effective, but it is not reaching an optimal drug level in the blood, and ensure a maximum efficacy of the drug. Now, there's a dose-dependent cleaning, a time-dependent cleaning, and a cumulative dose-dependent cleaning. Now, we've seen that the dose-dependent cleaning is aminoglycolide and quinolones. Therefore, a high dose and a low frequency, a OD dose is required. We've got something as a time-dependent cleaning, which is with your beta-lactams, azithromycin, linezolid, and clindamycin, and therefore prolonged infusions are preferred in these cases. And you've got a cumulative dose-dependent, where a single high dose or a flexible dose both work equally well when we see in clonolones, azithromycin, and vancomycin. So your quinolones work with a prolonged as well as an augmented dose, whereas your beta-lactams require a continuous perfusion. Now, the article published in 2020, we had seen that tackling the antimicrobial resistance in India, it's a very simple and important article which was telling us the overuse and improper use of antibiotics in our current clinical setting. This holds even more true in today's day and age, where COVID-19 becomes the most important cause of an upper respiratory tract and a lower respiratory tract infection. Now, what are the determinants of an antibiotic resistance? You agree that there's an appropriate and reasonable prescription, work pressure, fear of an infection and suffering. You refuse perception that infection is benign, a bacterial resistance, and a secondary gain and lack of trust. So it's very important when we decide when an antibiotic is required and to what patient population, in what setting it has to be given. A shared decision-making with the antibiotic, the sentiments, option, and information and check, and a proper discussion and follow-up with the patient, counseling of the patient and encouraging him and telling him that an antibiotic is not required has to be done when an antibiotic is not required. We must not give in to the patient's demand. When we see in COVID-19 that can we take an azithromycin 5-day course, can we take a doxycycline 5-day course, or even an amoxicillin 5-day course? No, it's not required unless there is a secondary infection with elevated counts or a procal level. Now, a GSK effort, the efforts by the pharmaceutical companies to mitigate your AMR, we have seen that GSK is leading as compared to the other multinational corporations, which is a very laudable approach for GSK. And a call for action that yes, antimicrobial resistance, surveillance, education for the antimicrobial resistance, patient safety, a public-private partnership with sustainability and research and diagnosis is extremely important in today's time. To summarize, antibiotic resistance pattern is a global problem. Much of the increase in MDR bacteria can be attributed to the overuse of broad-spectrum antibiotics. Efforts to develop new antibiotics over the past 2 days have lagged behind with the overdevelopment of resistance. A rational antibiotic use and optimal clinical outcome help to prevent the emergence of resistance. A shared decision-making helps to address what matters most to the patient and empowers their role in antimicrobial resistance mitigation by encouraging them not to use over-the-counter drugs and ensuring that only the clinician, physician, or family physician prescribes appropriate medication to them. To use or not to use antibiotics, the decision is in our hands, and we must use antibiotics responsibly, judiciously, so that we have antibiotics left when our future generations start practice and future patient populations do not have no medication left to use. Cefuroxime available 500 mg. Thank you.
Great. And great, sir, Dr. Avya Bansal. Really enjoyed your short and sweet lecture. It was really very informative. Good take-home message for all of us. Thank you, boss.
Thank you, sir. Thank you.
Thank you, Dr. Aviya. Nice section. Now I want to ask one question. If there is a no fever and only running of the nose and sneezing, what should we give?
I couldn't hear you, madam. There was a lot of disturbance. Can
जरा
you repeat your question?
आवाज जोर से बोलो जरा आवाज क्यों आ रहा है and बाजू का मोबाइल
Can you hear now?
Yeah.
please keep aside mobiles. No, your sound is not coming.
Please unmute, ma'am.
Sound is not there at all.
Yeah.
Now can you hear?
Can you hear now?
Yeah, we can hear now, Jitesh Mehta, but not the Dr. Usha. Jitesh Mehta is always laudable, you know.
अरे माझ्या नावातच लाड आहे.
Sir, without fever, running of the nose and sneezing, what will be the
Sound is not there, madam. Sound is not there. Something is going wrong.
Can you hear me?
Yeah, now we can hear you. Now we can hear you.
Can you hear me, sir?
Yes.
Ravya, can you hear me?
Yes, madam. Now I can hear you.
Yeah. Without fever, running of the nose and sneezing, particularly in the morning and bedtime, what will be the treatment?
The treatment will be steam inhalation. That's it. Observe for a couple of days.
Okay.
If it doesn't settle down, then maybe consider an antihistamine. Nothing else to be done.
Okay.
And if it's there early in the morning, it is typically known as a vasomotor rhinitis, which presents early in the morning, and that is due to an intrinsic allergy. So an antihistamine maybe for 5 days will help, but steam inhalation, nothing works more than that.
Sir, I have a question.
Yes, sir.
In this Omicron infection that was going on just now, all the patients complained of lot of throat pain and pharyngitis, and we were in a dilemma as doctors whether to give antibiotic or not to give antibiotic. There were definitely different thoughts that were propagated everywhere. Some consultants would tell us don't give antibiotics, some said, and some general practitioners wanted to give antibiotics. And our personal experience was that if we gave some antibiotic, there was a faster relief. So there is a big issue on this. Can you just clarify about this Omicron?
Yes, so to be safe and to be fair to the general practitioners and even physicians across boards, the most common use of antibiotic during the COVID era has been azithromycin and doxycycline, which are over-the-counter drugs and no benefit to the physician. So let's keep aside the monetary aspect and all those things. They've done it purely for the patient use. Now, there's a very famous saying: if you give an antibiotic in a viral disease, the patient will recover in 7 days. And if you don't give an antibiotic, the patient will recover in 1 week. So
1 week. 1 week.
I don't think any antibiotic usage is required in a viral illness. We have seen patients still complaining of throat irritation, hacking sensation in the throat, even after a couple of weeks of recovery from COVID-19. This is because the COVID-19 Omicron variant predominantly is present in the upper respiratory tract. Less than 0.1% will involve the lung. Therefore, all your CT scan scores will be 0. This is a predominant upper respiratory tract infection. Sore throat, pain, inflammation, these are common things. The secondary infection seen in COVID-19 patients is again less than 1%. So out of your all more than 100 patients having Omicron, less than 1 will require an antibiotic, to be very honest. Often due to poor oral hygiene and poor patient condition and comorbidities, a secondary infection sets in. So the patients feel that the antibiotic is helping them. Also, there is a placebo effect and peer pressure. That I have taken an azithromycin course, please prescribe me. The other doctor has given, please prescribe. So we as clinicians also feel the pressure to prescribe the medication. But trust me, it is not required. You and me, both when we fall sick, we don't take the antibiotic. We just let it be. Doctors are the worst patients. We'll probably take a paracetamol and go to the OPD the next day and start practice again, and not take the azithromycin or amoxicillin clavulanic acid unless our fever is not settling for a couple of days or we've got a purulent discharge. So in COVID-19 Omicron, if the patient is complaining of a purulent discharge, then consider an antibiotic. Otherwise, not required.
So in some cases, we have seen a lot of high white cell counts, and the patient is having a lot of symptoms of the pain in the ear and pain in the throat and swallowing problems
Yes.
and all that.
Yes, that will require an antibiotic. High WBC count will require an antibiotic. I would also recommend that if you have a high WBC count, just send a simple urine routine to see if there is a superadded UTI, or ask for a procalcitonin, which will tell you that yes, there is a concomitant middle ear infection or a bacterial rhinosinusitis picture which is set in. These patients are often diabetics and comorbid patients with an underlying disease. Your healthy, over stable patients will rarely present with such symptoms.
Right. Thank you.
Thank you so much,
Thank you.
Dr. Avya Bansal, for giving a very good information.
Really great.
About
Really
the
great.
antibiotic
Everyone appreciate it.
use of antibiotics. Yeah.
Yes. Now
Now we'll move to the next speaker. Now it is the JJ Merchant oration.
Jai Gurudev Teri Maya.
And our own Dr. Suchanisha sir, an immediate past president, is the recipient of JJ Merchant oration. Now I will give you a brief information about the JJ Merchant oration. Dr. Jamnadas Merchant was a renowned doctor of South Mumbai. He was very generous and kind-hearted. He, along with other stalwarts, Dr. R.V. Sathe, Dr. Arvind Shah, Dr. Panwala, and others went door to door and collected a substantial fund for the construction of building where we are all sitting at present, IMA Mumbai branch. In his fond memory, IMA Mumbai branch has installed the prestigious Dr. J.J. Merchant Oration Award to be given to the outstanding socialistic family physician. So today the J.J. Merchant Oration recipient is Dr. Suchanisha Attar, our own IMA immediate past president.
सुजाता पार्लर में जाके आ गई है, देखो कितना खूबसूरत दिख रही है.
You are right. Now Dr. Suja, I will give the introduction of Dr. Suchanisha Attar. Dr. Suchanisha Attar is a grassroots worker of Indian Medical Association. She is a practicing doctor, acupuncturist, and hospital administrator for over 20 years. She has to her credit MBBS, FCGP, DAC, IMAA, DHA, TISS. She is immediate past president of Most Vibrant Indian Medical Association Mumbai branch. She has the longest and successful tenure of 5 years as the honorary secretary of Indian Medical Association Mumbai branch. Currently, she is honorary joint secretary of Indian Medical Association Maharashtra State 2021 and 2022 and regular CWC member of IMA headquarters since many years. She was a director of IMA CGP Maharashtra State, was adoringly called CGP Queen and Iron Lady. She is a recipient of many awards. She has received Best President awards from IMA Maharashtra State and IMA headquarters in 2021. She is a recipient of President's Appreciation Award from local branch, state branch, and IMA headquarters. She is also a recipient of COVID Warrior Award from IMA Mumbai branch, IMA Maharashtra State, and IMA headquarters. She has gained expertise in organizing conferences, both local branch and state branch. In honor of our distinguished services to IMA Mumbai branch, is inviting her on the dais to deliver the most prestigious oration, Dr. J.J. Merchant oration. Today, she will deliver a talk Today she will deliver a talk on changing phase of healthcare in future. Over to Dr. Sujanta Attar.
Dr. Usha Shah, you forgotten one things to mention. She is a CGP queen of the IMA Mumbai branch and IMA Maharashtra state.
Already I had spoken. I had already. Yeah, it is there. I was already introduced.
And you forgotten today she is looking more beautiful.
So definitely.
क्या दिख रही है बाप पैसा वसूल.
Good morning, friends. Today I'll be speaking on changing face of healthcare in future.
Alan.
Your internet connection is unstable. Good morning, friends. Sure. What was healthcare before COVID? Before March 2020, most family physicians and consultants used handwritten prescriptions and telephonic appointments. Patients were examined physically and advice was given in person. As doctors, we were in touch with our patients and medicines were prescribed on letterhead and records were physically given to the patients. How COVID has affected healthcare? When complete lockdown was announced in March 2020, whole scenario was changed. All roads were empty. Only doctors and healthcare workers were allowed to travel. Only emergency patients were allowed to travel to clinics and hospitals. Most of the doctors were also scared to see the patients as they had their families back at home to take care of. Clinics were also closed. That is when telemedicine was allowed. Patients were advised, consulted in apps, video calling and Zoom meetings, and hence patient files were computerized. All this was done through smartphones, which played a huge role. The physical touch was lost. Only the symptoms were asked and parameters were told to be checked by the patients themselves and treatment was given accordingly. The hospital routine visits, admissions, checkups and investigations stopped as staff in small numbers were reporting to work. Routine operations were also stopped by the government to save oxygen, other resources and divert them towards COVID patients. Some hospitals were converted to COVID hospitals with capping from the government on bed charges, HRCT and other investigations related to COVID. Thus, COVID paved way for the people to become tech savvy. And then there was transformation in healthcare. Telemedicine became a routine as online consultation was allowed officially by National Medical Commission. A lot of patients who wanted to consult in emergencies and could not leave their homes because of lockdown restrictions. Patients started using various platforms for consultation and payments were done through different modalities like GPay, Paytm, debit or credit cards in advance. In the future of healthcare, we expect following key areas to collectively transform the existing health system. That is data sharing, interoperability, equal access, increase the awareness of health insurance, promote primary care and more funding for scientific research. Our Prime Minister, Honorable Mr. Narendra Modi, launched National Digital Health Mission on 15th August 2020. The mission aims to create an integrated healthcare system linking patients digitally by giving them access to real-time health records. also ensures doctors and organizations, thus and improving communication between referring doctor and specialist. And equal access to healthcare for those in equal need of healthcare also was given. Increased awareness of healthcare insurance was done because of the technological advancements has increased the cost of hospital care. Hence, patient needs to have health insurance policies, which is a must nowadays. Now, what are the trends in healthcare for the future? That is more patients, more technology, more information, the patient as the ultimate consumer, development of a different delivery model, innovation driven by competition, increasing costs, increasing numbers of uninsured, less pay for providers, and need for health reform. Now, more patients means the patient's life expectancy has increased because of technology, and now it has the ability to treat patients with chronic diseases, for example, heart disease, which also lengthens the lifespan of the patients. As genetic diagnosis and treatment translate from cell to bedside, the information available to the clinician will increase substantially over the next step. As the technology improves, the electronic medical records will not only be able to store patient information, but also provide information on best practices. This electronic data of the patient can be retrieved by the click of a button. And patients being the ultimate consumers, they surf the web and make their own choices of physicians and hospitals most convenient to them. And in future, they will also decide everything on whether the smartphone that they will be using, because all applications will be on it. With improved availability of data to the patient, process and outcome will improve. Patient care will be more regularized and more outcome-based. In the future, competition among practitioners will be more on account of the ability to innovate, developing the best care delivery models for patients with common diseases and developing new strategies for patients with uncommon diseases or presentations. Advancement in technology in medicine, more diagnostic tests will lead to higher care cost, and rise in healthcare costs will lead to higher health insurance premiums, which will lead to more uninsured patients, as patients will not be affording to pay high premiums. Now, the future of healthcare is shaping with advances in digitization of healthcare technologies, such as artificial intelligence, augmented reality, virtual reality, sensors, genomic sequences, 5G, 3D printing, drones, robotics, nanotechnology. The medical students will be benefited by attending lectures delivered by best of teachers at any place, and the scarcity of teachers will be taken care of. Online prescription will be the norm, which will go to the pharmacy directly from the doctor, and medicines will be delivered to patients' house directly. And microbots, these tiny bots can be used to diagnose or monitor a disease in real time. It delivers targeted therapies directly to precise locations, such as any cancer cells where they're there, it will be going and just hitting those lesions only. Then artificial intelligence and machine learning is the ability of a new computer or a robot controlled by a computer to do tasks that are usually done by humans because they require human intelligence. And this thing is now started at most of the places. And it is where this AI uses the computers and other machines which mimic human cognition and are capable of learning, thinking, and making decisions or taking action using patient data and other information. It can also help doctors and medical providers deliver more accurate diagnosis and treatment plans and lead to better patient outcome. And the applications of artificial intelligence is seen in chatbots, which has the power to increase primary care and triage, robotic surgeries, precision medicines, administrative workflow assistance. What are the benefits that we see of AI? It provides real-time data by diagnosing and addressing medical issues and acquiring accurate information in a timely manner. It also streamlines tasks, it saves time and resources, and assists in research. Now, augmented reality is the latest technology which would make a great change in the near future. It merges virtual images with the real world, including real objects and real people. That means surgeon, doctor, or nurses could see things in front of them using augmented reality, that they bone, brain tumor, X-ray, or health records. The applications of AR in healthcare, it reduces the risk of complicated surgeries, and it also makes the job easy for doctors. Nurses can find the veins easier, as seen in the diagram. AR features wherein by scanning the name on medicine bottle, entire details will be visible, including side effects. The medical students, while studying anatomy using AR app, they just detailed 3D model in which they can explore inside the internal organs. Virtual reality is the next technology which enables a AR headset within a machine-generated atmosphere. In healthcare is many, and it helps in the medical training of the students, the treatment of patients, pain management, physical therapy and rehabilitation, addiction, health education, and fitness. Then there are healthcare trackers and wearables, which plays a major role with patients' data to be got on the smartphone, and they help them to monitor their sleep, exercise, sugar monitoring, BP monitoring, heart rate, and oxygen saturation. These devices help patients to monitor their health at home and share the results remotely with their physician. Then there are medical tricorder, which is a handheld portable scanning device to be used by patients to self-diagnose medical conditions within seconds and take basic vital measurements. With these gadgets, one can diagnose and analyze every disease with a wide range of parameters like respiratory rate, heart rate, temperature, body position, activity level, sleep status, gait, and more. Sensors, these are used nowadays in electronic-based medical equipment to convert various forms of stimuli, electrical signals for analysis. These can increase the intelligence of the medical equipment, such as life-supporting implants, and can enable bedside and remote monitoring of vital signs and other health factors. There are various types of sensors which are used, like the temperature probes for measuring the temperature, force sensors for kidney dialysis machine, airflow sensors in anesthesia delivery system, laparoscopy, and heart pumps, and pressure sensors in infusion pumps and sleep apnea machines. Then there are implantable pacemakers, oximeter, glucometer, magnetometer. There are electrocardiographic sensor, heart rate sensor, electroencephalogram sensor, electromyogram sensor, which all records the electrical activity of the brain and the skeletal muscles, and respiration rate sensors. Then we come to a new technology, that is the genomic sequencing. What is genomics? It is the study of genes. It helps precisely and personally. Early diagnosis of a disease can significantly increase the chances of long before symptoms present themselves. And genomic sequencing is figuring out the order of DNA nucleotides or bases in a genome, the orders of A's, C's, G's, and T's that make up an organism's DNA. The human genome is made up of over 3 billion of these genetic letters. This is how the sequence will be looking when a DNA sequence is translated from life's chemical alphabet into our alphabet of written letters, which looks like this. 5G. 5G is coming in a huge way by the end of this year, and it will really transform the healthcare system because it would prove valuable in many areas of healthcare, including telehealth, remote surgery, transferring large medical files, tracking patients' movement inside facilities, using wearable devices for real-time monitoring, and delivering continual treatment information and support to patients. Doctors also can use 5G to wirelessly connect to the internet and exchange data through cloud. What is the 5G capabilities? It has speed, capacity, hyperconnectivity, low latency, massive device connectivity, and data-driven insights. The applications of 5G in healthcare It's a technology which is expected to enable telemedicine due to the lower latency it offers. It is expected to make telesurgery possible due to its enhancements to robotics, which would then aid surgery. There can be language translators, which will be able to video conference with the patient and the doctor. Robotics, autonomously or semi-autonomously performing medical procedures. Better leveraging of artificial intelligence tools, better access to more specialists for collaboration, remote patient monitoring, augmented and virtual reality, large file transfers and data analysis. Medical applications of 3D printing are expanding rapidly and expected to revolutionize healthcare. And the major applications of 3D printing are bioprinting tissues and organoids. One of the many types of 3D printing that is used in the medical device field is bioprinting. In bioprinting, instead of using plastic or metal, a computer-guided pipette is used to layer living cells, referred to as bioink, on top of one another to create artificial living tissue in a laboratory. These tissue constructs organoids which can be used for medical research as they mimic organs on a miniature scale. They are also being trialed as cheaper alternatives to human organ and transplants. Another application of 3D printing is creating patient-specific organ replicas that can be used by surgeons to practice on before performing complicated operations. 3D printing in the medical field can be used to produce prosthetic limbs that are customized to suit and fit the wearer. Sterile surgical instruments such as forceps, hemostats, scalpel handles, and clamps can be used using 3D printers. What are the advancements in medtech? The industry of health and medicine is not the same as it was about 10 years ago. This has changed due to medical advancements. Medicines would not have been able to make discoveries like today if it was not for the technology. Every day we hear things about new technological breakthroughs and innovations. These advancements of technology have taken over the world and are leading to a great change. So friends, the take-home messages: update yourself with time, else you will become obsolete. Taking no risk is the biggest risk. Take risk and adopt new technologies. Age is just a number. You can learn at any age. Healthcare will drastically in next 10 years. So keep yourself abreast with new technologies. Thank you for your patient hearing.
क्या लेक्चर डिलीवर किया बाप, पैसा वसूल, हटा साउंड की घटा, पैसा वसूल बाप, पैसा वसूल, हटा साउंड की घटा और अपना वाला बजा. ले भारी तुझा enjoyed. Great lecture.
Thank you very much, Dr. Usha.
Usha?
Thank you, Dr. Sujata for giving a wonderful information about the latest technology. Now I request our president. I request our president, Dr. Jitesh Mehta, to felicitate our own Dr. Sujata Akhtar.
Really appreciate the great lecture and good content of the lecture. Really good content. It has explored the total medieval world for all of us.
Yeah.
Hats off to you. Thank you so much for delivering a great lecture.
Look this side. Turn. Sir, थोड़ा इधर turn. हाँ. Turn थोड़ा सा. Congratulations.
अरे जोर से ताली बजाओ यार.
Congratulations, Dr. Sujata Attar.
Excellent presentation. Really excellent presentation. Enjoyed. She has covered each and everything in the.
Yeah.
Great. सुजा क्या दिख रही है बाप पैसा वसूल
सेंटर ही दिख रहा है साइड दिख रहा है
Thank you.
Welcome back.
Now the next program is the elocution competition. Now the chairperson of this elocution competition is Dr. Arvind Patel. I request Dr. Arvind Patel to take the mic. Over to Dr. Arvind Patel.
Good morning, all of you.
Good afternoon.
Dr. Swapnil Kale is the editor of Bulletin of Indian Medical Association, BIMA. But in his absence, Dr. Jitesh Mehta, our president, has given responsibility to me to conduct this entire program, and with privilege conduct this program. Online IMA BIMA elocution competition for Dr. V.H. Salaskar rotating trophy and prizes by Dr. Lalita Rao, former health minister of government of Maharashtra. Before we proceed with this competition, it is very apt to mention about Dr. V.S. Salaskar and Dr. Lalita Rao. Dr. V.H. Salaskar was a renowned pathologist of South Mumbai and president of IMA Mumbai branch. Recognizing the contribution towards social activities, the government of India nominated him as Rajya Sabha member. He was a very dedicated member of our branch. He always propagated that doctor should have effective communication skill. To encourage the communication skill and shed stage fear, he started extempore elocution competition, which is now known as Dr. V.H. Salaskar rotating trophy, BIMA extempore elocution competition. To mention about Dr. Lalita Rao, she was the president of Indian Medical Association Mumbai branch. She was the only lady from Mumbai branch to become national president of Indian Medical Association. From Dakshin Kannada district, she migrated to Mumbai at the age of 17 and completed her medical graduation. She served as the Maharashtra State Health Minister during 1980 to 1985. She also represented India in the American Medical Conference in the year 1979. She is a recipient of various awards and felicitation for her social services. She is credited of introducing various innovative health programs both at the state and the national level. BIMA elocution competition cash prizes are sponsored by her. Now we proceed with BIMA elocution competition. Some of the rules and regulations were already posted on WhatsApp, and I'm sure the participant must have gone through it. The competitors will have the option to speak for or against the proposition. Each speaker will be allowed to speak for 5 minutes only. 3 questions only will be invited from the audience. There should not be any comments. If any judge or the chair wishes to ask any question, it will be an extra question. There will be 3 judges. The competition will be in English. The competition will be judged on appearance, presentation, substance, questions and answers. Total 40 marks. The decision of the judges will be final and binding to all. The winner will be awarded Dr. V.H. Salasker Rotating Trophy plus cash prizes donated by Dr. Lalita Rao and a certificate of merit. First runner-up will be awarded cash prize donated by Dr. Lalita Rao. Second runner-up also will be awarded cash prize donated by Dr. Lalita Rao and a merit certificate. The trophy, prizes, certificates of merit will have to be collected by winners from IMA Mumbai branch. Elocution competition is free for all participants. Today, we are honored to have judges. Our great Dr. Vijay Punjabi sir, past Vice President, IMA HQ, past President, IMA Maharashtra State, and past President, IMA Mumbai branch. We have Dr. Girish Lal as second judge, who is Honorary Secretary, IMA Mumbai branch. And the third judge is Dr. Prakash Borana, past Vice President, IMA Maharashtra State, and past President, IMA Mumbai branch. I'm sure I have made everything clear to the participants. We begin our competition, and our first speaker in cricketing terms, the opening batswoman is Dr. Anjali Patel. She has chosen to speak on should school curriculum be restructured. Over to Dr. Anjali Patel. Please come.
Good afternoon, friends. Yes, should the school curriculum be restructured? I'm speaking for it. So, as the Greek philosopher Heraclitus said, so when we talk about change, what is, one minute. Stand over this. I'm okay. I'm okay. I'm sorry. So let's get back to the change. So is there a necessity for a change? What does change do? Is there a change in the scenario, in the existing circumstances that require this change? Are there some improvements that can be made by the change? Are there deficiencies in the previous system that we require change? So when we look at about the school curriculum being restructured, do we need this restructuring of the change? So to understand that, we need to understand whether the school curriculum as at present is catered for the present needs. And secondly, is it achieving the goals of an ideal school curriculum? And the second question that we need to answer is that could we make some changes, and would these changes be appropriate to bring about a change and achieve these goals in removing the deficiencies and improving the system? And last but not the least, what are these changes going to be? And as a doctor, what are the doctor's perspective on our school curriculum? That is also very important, because a doctor is concerned not only about the physical health of our society, but also the mental health of the society. So let's begin with the first question. What are the defects in this? Let's start with the first question, that is, what is the aim of an ideal school curriculum? The ideal school curriculum is to prepare, the goal is to prepare you for further life. If I'm a child,
What is my life going to be ahead? Am I prepared? Is my school curriculum preparing me for it? Or it has deficiencies? Does it prepare me for a job? Does it prepare me for relationships? Does it prepare me for doing my day-to-day practical activities? Does it prepare me for if my investments, my economic stability, for my savings, looking after my parents, looking after my responsibilities as a family member, looking after my responsibilities as a part of society, and as my responsibilities as a citizen of this nation. So does our present system cater to these and achieve these goals? I would say that a lot of these things are deficient. Am I being prepared for the job that I have to do in my school? No, we lack a lot of knowledge. We don't know what vocation that we are going to go to, and practical things are not taught to us in our present curriculum. So this definitely needs to change. What about day-to-day living? If my tap is leaking, am I getting a practical knowledge about, yes, why is the tap leaking? How can I repair it? Or if my tube light needs to be changed, can I change it when a simple person like an electrician can come? So what is the kind of vocational training that I get? I have to get a little bit of basic knowledge. Do I know how to prepare a legal document when I'm in school? Do I know how to go to the bank, fill up the checks, or how fill up forms? No, I'm not prepared for this in school. So if life is going to be about this, why does our school curriculum not teach us all this? Today, the scenario is not the same as many years ago. The scenario has changed. We are living in a world where both the parents are working. So when both the parents are working, they would like to, they will not be able to give the child as much time or to create in him certain values. So these values have to be created in school. There are no grandparents there. So all these values of love and care have to be created in the school itself. And if this joint family system is lost today, if both the parents are working, then the child has to also be prepared for certain things, that when he comes home, he's going to be alone. So are we teaching our child how to prepare a simple meal at home? And there are different ways of changing our school curriculum, which we could easily do it. Why is our evaluation system based on marks only? Why can't we have an incentive-based evaluation system that, yes, if I know all my tables up to 10, I will be taken for a movie, or the entire class will be taken for a movie. I mean, rather than, and if a teacher is going to spend about half an hour on the history lesson, should he or she spend another 1 hour to see what the children have learned out of that history lesson? Like if he is being taught the lesson on Shivaji, does he understand what were the relationships between Shivaji and his mother, and why Shivaji became what he was today? We do not learn these backgrounds. We are not taught to make a critical assessment or a think critically on any subject. If we were told that, no, if you were born in the era of Shivaji and you were born as a locksmith, or you were born as an ironsmith or a potter, how would you have contributed to that historical era? Would you have joined Shivaji's army? So the children will come with all kinds. This is known as critical thinking. We have to think out of the box and make the children question what has happened, make the children debate, and also to think critically and out of the box. Plus, we need to evaluate or innovate. So all these points should be considered, and I would definitely say that we need to make these changes, and the school curriculum definitely needs to be restructured, not in the sense of making the 10+2 system into a 5+4+3+3, 5+3+3+4 system, or rather the very basis of teaching should be changed, because schooling does not only involve your futures. The second point that I must, and the most important, is that the school is also the child's present. And if it is your present, it has to be a happy one. You should be happy going to it, and you should come back out of school with cherished memories of that time. And today, with the passing of Lata Mangeshkar, I certainly remember her song on Bachpan. Bachpan ke din to bhula na dena, aaj hase ka kal ruda na dena. So we must think about that Bachpan should be a time of happy memories, happy times, and school should be a time that is spent outside in the nature, with trees around you, with birds around you, hugging your animal life with fun, togetherness, and a positive outlook in life, and make you into a person who respects yourself with eminent self-respect as well as respect for society. Thank you so much. Are there any questions?
Hello, any questions? Any questions from the online audience? The judges may ask questions.
Madam, very nice about what should be the changes. Could you define, tell us what should be a division of years that the education should be given to the children? What level they should be the class, and from which level will be taken outside, and also not only the academic, what about the other activities?
Yes, where learning is concerned, where curriculum is concerned, no time is ever enough. But when we talk about the school curriculum, basically previously it was divided as a 10+2 system. But now the system that's changed recently by the government is going to be a 5, in which the 3 years will be a preschool child will not have any exams at all. It will just be at all play, which is known as the foundation. After which the children for 2 years would be in the preparatory stage, where certain topics to expect, but there will not be any exam. So basically, there will not be evaluation. That is where I feel that when we are talking about evaluation, rather than having evaluations, why we are not having evaluation in the after the preparatory stage onwards in the middle and in the secondary school that we had. That time we do have evaluation. So if we have evaluation, it should not only be for the school, for the child, but also should be an evaluation. The teachers, interaction with the other peers, that is that, and self-evaluation also. And it should be more of incentive based. So up to the age of at least, children are in school up to at least age of 18 years of age. So they should be prepared for their graduation, that is post-graduation after that.
And at what level they should do sex education?
Of course, I definitely believe that sex education has to be given to the child. And what period it will be given, I would say that it should be given at a very early starting time, rather it can be started right at the foundation stage itself, so that the children are aware and are respectful and are whatever what is the natural phenomenon is present, what is naturally present.
Yeah, Dr. Lad, just a request.
Usually, you said that there will be no assessment in the first foundation time. Assessments are of 2 types. One is objective and another is subjective. So, like kindergarten, teacher knows which child is better, which child is lacking in some activity, additional activity. So I do not agree with you on this ground. There will be no during that initial phase, you cannot assess them. Because I think it is something called a subjective assessment assessment that has to be done by the teacher or anyone who is now in a class or vicinity. Any comment on that?
Yes, you have a very valid point out there that teacher definitely evaluates the children, but evaluation at that stage should not make one child to be okay. This child is not enough. This child is not good enough. It should be positive assessment in healthy manner. We want to make the children confident in life. Even if they are lacking in something, it is the teacher's responsibility that the child does well. It is her responsibility that the child fails. If a child is successful, it goes to the credit of the child. If the child fails, to the credit of the failure of the child fails. That's what it is the failure. And of course, that's what I believe. And of course, I did not answer one question that Dr. Prajapati had asked about curricular importance of curricular and extracurricular activities. Extracurricular activities are definitely as curricular activities, the overall development, and as also should be as your part of an evaluation when you go for your job or finish your schooling.
Yes, sir. Can I ask one question? Do you promote Gurukul system education?
Gurukul system. Gurukul system does have its advantages. I would say that staying in an atmosphere, what Gurukul had is an open air schools and being in nature, being with nature is definitely good. But Gurukul system also had its disadvantage because it is very subjective based and is dependent only on the teacher itself. So if you do not if you land up in the wrong with the wrong teacher, or you would lack good teaching if you do not have a good enough teacher. So we cannot guarantee a good teacher in the Gurukul system. Yes, if we could modify it to suit today's needs, definitely I would want that. Thank you.
Thank you, Dr. Anjali. You made a good beginning. We really appreciate your effort. Our next speaker is Dr. Sachin Patharkar. Organic farming, a myth or a reality? Welcome, Dr. Sachin.
Good afternoon, everyone. My name is Dr. Sachin Ashok Patharkar, and I am speaking on organic farming, myth or reality. So what is organic farming? Organic farming is the farming, it is a form of farming where the use of compost, manure and techniques are emphasized, such as crop rotation. Then there will be the harvesting of the predators. So all the natural ways of farming are inculcated and promoted for the formation of the or practice of the organic farming. So organic farming, use of organic farming began in the 20th century by the couple Howard, Gabriel Howard and Albert Howard. They founded the Institute of Organic Farming in 1921 in India. And they trained the farmers and the institutions for promoting the organic farming. Why there is a need of organic farming? All of us as a physicians are aware of the disadvantage of the traditional farming. So what is traditional farming? Traditional farming is the use of the synthetic pesticides, use of the chemicals, use of the genetically modified seeds, use of the genetically modified animals in husbandries. So all these had a certain definitely short-term advantages. What was the short-term advantage? There was a rapid increase in the production of the food quantity. And why it was needed? In 1968, India was very much dependent on the foreign food, foreign grains. And then that time, so former Prime Minister Indira Gandhi led to the foundation of this Green Revolution, where in 1970 our total agriculture production was rise to more than 70% of that time, increase in that production. But later on, we found that these short-term gains are highly dependent on the long-term side effects. So, what was the long-term side effects? There was the decreased soil integrity, soil fertility. There was a decreased long-term health benefits on that. So many times farmers themselves that time complain that there is the decreased production of the or reproduction of the foods animals who have fed on that kind of the plant. And similarly, then the research began for the long-term disadvantage of that kind of the pesticide use or a hybrid use farming. Then later on in 2000, India has developed its own policy, a national program for the organic farming, and in 2004 then it is promoted, the corporation is inducted for the formation of the organic farming. 2018 we started with the zero budget natural farming, and our Prime Minister said in his own language that ये सेंद्रीय खेती इंसान के लिए और जमीन के लिए बहुत ही लाभदायक है और इससे अच्छी कीमतें मिलती है. So in his own language, he promoted the organic farming for the benefit of the sand and the people of this sand, and also for the increased revenue of the sand farming. But there are certain disadvantages. What are the disadvantages? See, organic farming is not possible for all everywhere. The production itself will go drastically decrease if the ways and techniques are not proper enough, if the training is not given them. And most of you know they are dependent upon the compost manure. Also they use earthworms, which in Marathi we say gandul kheti. So these are the things, but they should get the supply chain should not be interrupted, and the training should not be interrupted, and the proper standard should be maintained, as this is the era of the standard maintenance, be the standard in the hospitals or it should be in the standard in the farming. So standard should be maintained. That is a big challenge for the organic farming. The chain supply, there should not be adulteration in between the production and the end user. So these are the bigger challenges. As rightly pointed in my previous speaker, she has created here an atmosphere of Lata Didi's song. I also remember, not Lata Didi's, but I also remember one Bollywood song from the film Upkar. Mere desh ki dharti sona ugle ugle hire moti. So if we really induct ourselves, train ourselves, we will definitely do miracle in organic farming. It will be a reality, not myth, provided it should be designed properly and implemented properly. Thank you very much.
नहीं उसको ऑडियंस को wants to ask audience.
Any questions from the audience, please? Questions from the audience.
Yeah, Dr. Sat, no audience question.
Dr. Panjabi, sir.
Dr. Sachin, could you tell us the financial involvement of organic farming? And
financially, we don't have the data here, but
and what will be the technical know-how required for training the farmers?
sir, financially, we have the data of the US right now. When it started, total overall revenue or the market share of this organic farming was 20 billion, and in recently increased up to the 80 billion. US dollars. So next question is that the training. Next question is that the training. Definitely, we have the policy in hand. Who will do? What kind of crop rotation is required? Because crop rotation is one of the very important. And not only crop rotation. Crop rotation means they should change the crop every year. But which crop should be changed? That kind of the knowledge should be given based on the individual soil quality and individual atmosphere or environment of that particular continent. That is one thing. Another thing that the salt there should be the crop companion. What is the crop companion? One crop along with other crop. Not only the rotation, but the crop companion also should be there. There should be the proper spacing of the two crops. That is called the distancing of the crop distance. So these kind of the technical details, which already our ancient farmers practices, but in the few years to increase the production of that, these things gone behind. For example, I am from the Marathwada. Their everyone is going to cultivate the production of that, and that is not wrong on that part, their part, because no other crop is that kind of the production is not occurred in previously. Similarly, in Paschim Maharashtra, there is everywhere there is a sugar cane is cropped every year. So that kind of the training, it will be imparted through our present agriculture institute. There is agriculture ministry is there, agriculture officer is there at each and every gram level. So we can implement that kind of the program from them.
Are you aware about the Sri Lanka crisis?
Yes. Sri Lanka had recently banned all these kind of the pesticides and synthetic material for the farming, and they landed into the greater tragedy. They are now dependent on the food for each and every item. So that is the disadvantage of the organic farming. Just I briefed in my talk, if it is not technically done, we will be pushed back beyond in 1970s, where we need this traditional farming change because of our dependency on the foreign countries for our grains.
See, if you become a farmer, which one you will prefer?
See, bottom line of this talk is that you should have the balance between both the things. There are certain fertilizers are allowed. For example, ivermectin, which we use here, that can be that is mentioned somewhere in that can be used as a pesticide. There are also some predators. So the techniques, there should be a balance between your certain portion should be given to the organic farm and certain portion to be given to the synthetic or traditional farming. Just to balance, we should be able to supply the good quality of food. More research is needed to lessen the harmful effect of our traditional farming. Thank you very much.
Thank you, Dr. Sachin. It was a wonderful talk. Our third speaker is Dr. Indira Sahajwala. Madam, are you on the line? Dr. Indira Sahajwala, please. Dr. Vijay, can you see whether she's on the line or not?
Dr. Indira, please unmute.
We move to...
Yeah, she is there.
Madam, you are there?
She is there. I can see her name there. She has to unmute herself.
Madam, please unmute yourself.
Yeah, she has unmuted.
Vijay, can we see her? Okay.
You can't see her.
Her video is not on, but she has unmuted herself.
Madam, please switch on your video.
I've added her as panelist. She'll be there soon.
Vijay, just coordinate with her. Till then, we take the second speaker. Just coordinate with her, please. Our next speaker is Dr. Dakshini Kashyap. Is artificial intelligence replacement to clinical skill? Dr. Kashyap, the mic is yours.
Thank you, sir. Is artificial intelligence a replacement to clinical skills? I speak on behalf of no. Artificial intelligence. It is the ability of a digital computer or a robot to perform tasks which are commonly associated with intelligent beings. Development of systems with intellectual processes, characteristic of humans, the ability to reason and learn from past experiences. It is basically a way of emulating what a human being would do based on past data and past decisions. Google uses a lot of AI in day-to-day products and solutions. In fact, predicting what are your food choices, predicting the choice of restaurants, predicting reading topics of interest, and predicting music. In AI, we have machine learning, deep learning, neural networks, amongst others. Some examples here again. People would play chess with a computer, or people would play video games against a computer. So a computer is playing on behalf of a human being. In medicine, AI can assist doctors in monitoring patients, in answering commonly asked questions to patients, in helping communication between hospitals and patients, and in patient engagement. Some of the applications of AI include clinical chatbot, robotic surgery, and virtual nurse assistant. So how would AI work as a replacement to a clinician? Inputs would be a patient history or clinical examination findings, and the output thereafter would be the investigations which are recommended. Again, inputs would be history, examination findings, and output, and also the findings of clinical investigations, and the output would be diagnosis or medical treatment, dietary advice, or lifestyle modifications. Thus, AI is of good help or assistance to doctors. However, the replacement of clinical skills by a doctor by a machine is far-fetched, unlikely, unconvincing, and implausible. The human touch of a doctor, the empathy of history taking, the personal history confidence is irreplaceable by a machine with no emotion. The human touch during clinical examination, the confidence that a patient gets by being examined by a doctor, the satisfaction that a patient gets by being examined by a doctor, the ability of a doctor to think of uncommon manifestations of common problems and common presentations of uncommon diseases, correlating history and clinical findings, inspection, palpation, percussion, and auscultation, has a long way to be thought through by AI. Besides, artificial intelligence is learned by a computer. So therefore, if there are errors based on past data, then these errors are likely to be repeated by machine output. Truly so, AI spends by pharma companies and healthcare companies is expected to increase from $500 million in 2019 to about $2 billion by 2025. My concluding remarks. AI is just how we have for machines, is a very good servant, a good assistant to doctors, but a bad master. A replacement for clinical skills is a no. Thank you.
Thank you, Dr. Dakshini Kashyap. Wonderful talk. Any questions from the audience, please?
Yeah, can I ask a question?
Yes, sir. Please.
Yeah, Dr. Kashyap, you said that AI is a bad master, but a very a fantastic servant. I agree with that. But do you think AI has any role to play in, especially in India today, in the small towns and villages where we do not have enough of doctors, and the ratio between the population and the doctors is so abysmal? So would you agree to it that we can make use of AI in such places to augment the health care as far as that population is concerned? And what are your views on that? And what are the limitations also, since you said you do not agree that AI is for replacing doctors?
Right, sir. So in remote locations, of course, we have telemedicine. Telemedicine is, a way by which doctors who are, more commonly practicing in urban cities and towns can actually reach out to the rural population. However, if one looks at AI, then one would be able to use some bit of predictive modeling, some bit of inputs of past data, and try and predict what could be the likely diagnosis or what could be the likely investigations which could be carried out, and what could be the likely treatment. However, so that would enable a doctor, if there is a doctor who tries to use AI, then it can save some time for him. So he could probably get a predictive diagnosis right in front of him. So he can use AI, by doing that, but definitely not a replacement. So one could use a combination of telemedicine and artificial intelligence to be able to tackle and serve the rural population.
Questions from the judges, please.
No question. Yes, if you require the artificial intelligence, you require the more knowledge about that.
Hello.
More study.
Hello. Hello.
Of death.
Can I ask you one question? Dr. Anil Patnekar over here.
Anil, na?
Yeah. Can I ask you one question?
Yes, go ahead, please. Go ahead.
Kashyap, taking the COVID era into cognizance, is the AI is a boon or a curse? Is it not the AI which is helpful for the medical fraternity or the human beings?
Absolutely agree, sir.
Surgeon will not able to reach the to do the surgery, but the robotic surgery will be accessible.
Definitely, sir. AI is definitely a boon as a servant. So as and when the computer learns, through machine learning, through back testing, through past experience, through emulating the skills of a surgeon or emulating the skills of a physician to diagnose well, it can definitely help. And it's definitely a boon in disguise to reach out, more in terms of through telemedicine or through learning or through deep learning or through neural networks. Definitely, it is a boon, although not a complete replacement for a doctor, is my perspective, sir. But definitely, it would help in increasing the number of patients that a doctor can serve.
Thank you. You delivered an excellent lecture. Good. Good. Thank you. You delivered an excellent lecture. Can you hear me?
Thank you, sir.
Yes, we do hear you.
Yeah. Go ahead.
Thank you, Dr. Dakshini Kashyap.
Thank you, sir.
Till we coordinate with Dr. Indira Sahajwala.
I think she's
Our
there.
next speaker.
I can see her.
Yeah. Madam, are you ready? Madam, I can see you. Dr. Indira, madam, are you comfortable? Madam, please unmute yourself.
She's unmute.
Madam, please start your talk. Indira madam, we can't hear you.
No, she's not talking. I think explain to her what has
Madam,
to be
please.
done. Go to the next speaker by that time.
Indira madam, we will get back to you after the next speaker.
Okay. Okay.
Oh, yeah, you are. Madam, just unmute yourself. First, you unmute yourself.
Please unmute. She has unmuted. You can hear her.
She's making an attempt to. Yeah.
Madam, do you want to go on with your talk, madam, just now?
Sir, we take the next speaker. Uttari sir, we take the next speaker.
Yeah, go ahead.
Our next speaker is Dr. Pradeep Kapsikar. Medical professional be allowed to advertise their skill. Dr. Pradeep, are you on the line?
Yes, sir. I am on the line.
Okay, go ahead. Yeah, go ahead.
Good afternoon. Good afternoon, everyone. Myself, Dr. Pradeep Kumar Kapsikar, and today I am talking about the topic whether medical professionals should be allowed to advertise their skills or not. So, first of all, we should understand that there are 2 points. One is it illegal by law, and second is it illegal by ethics. So, what is ethics in this? So, medical ethics, which is formed centuries ago, it's still continuing. And this ethics, what does it say? It says that a medical practitioner should not be soliciting of patients directly or indirectly. The basic dogma is that the medical practitioner should not be greedy. He should not force his patients to take treatment from him only. So just for the benefit of the patient, at that time this ethics was created that a doctor should not be greedy. But from day by day and yearly, the medical profession has changed a very lot. Currently, the medical profession is strictly becoming as a business profession. A doctor has to pay his taxes as a business tax. He also has to pay his electricity in hospital as a business electricity pay. There is no subsidy for healthcare workers who are working at the hospital. So even the Medical Negligence Act, these are also based as a treating patients as a consumers. So once you have started to consider patient as a consumers, so that means you should be agreed that medical practice is also now a business practice. So this is also other point is that why should a doctor should not be allowed to earn money? Earning money is everyone's right. A doctor has a family, a doctor has a child, doctor has parents for whom he should earn money. If a doctor is not earning, then where should his family go? Is there any subsidy? Is there any facility to educate his children? Do we have any facility like those who are in armies, their families get benefit? If doctor's family is not getting any benefit, then why should a doctor should not be earning money? So we need to change according to the current age and era. Also, we are bombarded with lot of advertisement which are related with the medical field. Like Doctor ka sujhaya #1 person means a layman who is not even graduate is wearing apron and stethoscope and advertisement publicly on national challenge that doctors can sujhaya #1 person means this is logical and this is legal. But even if a doctor who is expert in his field cannot advertisement his own skills, so it is not equity. Even, and this is against the justice to the patient and public. The code of ethics of Medical Council of India were relevant to that age, but currently we are in the digital age. If a person wants to know if he has a bronchogenic carcinoma, which hospital should he visit, which doctor he should get. So there should be the facility that general public should be aware that what kind of a medical practitioner, what kind of specialist he needs, and where this specialist is available in which hospital. So this information should be publicly available for the benefit of patient and public. Suppose if you are making a website and putting an information of a doctor and specialist on that, and the patients are getting information. So if getting information may also, and handling website also may cause some cost. So will it be considered as a advertisement? If it is advertisement, and this advertisement is getting benefit to the patient and general public, then this should be allowed. There should be revision in the medical practice. I also recommend that if layman person if can make advertisement that you come to us and we will completely treat your obesity in 1 month, your hair loss will be treated in 1. Even there are so many cases that when diabetes, hypertension will be completely cured in 2 months. These advertisements are done by non-allopathics, and these are allowed. So what is making the general public is unaware of the existing specialist? Instead of this bombardment of advertisement are making general public to go to those illegal persons and take the treatment from them, which are actually not getting any benefit from this treatment. So I suggest that the Medical Council of India, NMC, and the State Medical Council should be come forward to make some guidelines regarding advertisement in medical field. And there should be this guideline should be regulated, and doctors should be allowed to advertise his skills, not for his personal benefit, but for the benefit of the general public and the patient. Thank you.
Thank you, Dr. Pradeep Kumar.
Yeah.
We go back to the judges for the audience for the questions.
Can I ask a
Questions
question?
from the audience, please? Yes, Uttare sir, please go ahead.
Yeah, Dr. Pradeep Kumar, I agree with you. You're a youngster. You're thinking of the future. But 2 questions I have for you. Number 1, is there any other profession which is allowed to advertise as far as India is concerned? Number 2, there is a concept of ethical advertisement which you have not spoken about at all. And in which countries are they followed? And I would have been very happy if you had spoken something as far as I agree. Advertisement has to be, you should allow doctors to advertise in today's era. But you cannot just open up the whole chapter of advertisements for everybody. It is not going to help the doctor, nor it is going to help the patients also. Because it will be that the person who has more money will advertise more. And you're talking about gaining patients and patients being empowered to know what the doctor is doing. So that will all depend on how much money you can spend on your advertisement. So are you aware of anything called ethical advertisement, and in which countries it is going on? These are the 2 questions I would like to ask you.
Hello, sir. Hello, sir. United States and America, I think American Medical Association has given guidelines for ethical advertising by physicians. And also United States, the court has also has one statement regarding right to free speech by doctors.
And my second question, which other profession is allowed in India? And what is ethical advertisement?
Ethical advertisement means whatever you are advertising, it should be true and not the fraudulent. Other professions, hotels.
Profession. We are not talking about service sector.
Yes.
Lawyers, architects.
No, sir, I'm not aware.
Okay. Anyway, just for information, US, UK, Australia, Germany, all are allowing what is called as ethical advertisement. That is come way back in 1982. What you are talking about, the court in America has said that banning advertisement by doctors is not allowed, and that's when they started advertisements in the USA. But there are some rules and regulations which are laid down. We are also in NMC, National Medical Commission. We are in the process of making these rules and regulations. Let us see if we can come forward, because this is a very touchy subject as far as advertisement in medicine is concerned. So good, at least it's good that youngsters like you are thinking about the future and creating a level playing field for the doctors vis-a-vis the corporate hospitals and the institutions. Thank you.
Sir. Thank you, sir. And I understand it is complicated, but we should be regularized it. Thanks.
Any more questions from the audience, please? Questions from the judges, please.
Hello, Dr. Pradeep. If we allow the advertisement, then people who spend more on the advertisement will put impressive advertisement, and which will be misguiding the public. So do you think it is advisable blankly to allow medical professionals to advertise?
Sir, I'm not able to listen clearly, sir. Can you repeat your question, sir, please? Can you repeat your question, sir?
Hello?
Yes,
did you hear the question?
No, sir. Please repeat your question.
Pradeep Kumar, आपका वीडियो ऑफ कर देना, then you'll hear better. Yeah,
Hello?
Punjabi sir, go ahead, sir.
Dr. Pradeep, can you hear me?
Yes, sir.
Okay, I want to ask you that if professionals are allowed to advertise, then the person who spends more on the advertisement will put impressive advertisement, which will give the wrong impression to the public, and it will be a biased advertisement. So you think they should be allowed to advertise?
Sir, there are pros and cons. So I really agree that completely giving freedom to advertise anything is wrong. But we should regularize each and everything, advertisement, and also there should be some limit that how much you can advertisement. So we also can regularize the monthly how much income is spent on advertisement. So we can enforce some लीगली वी कैन मेक उनके ऊपर हम कुछ तो निर्बंध डाल सकते हैं. कंप्लीटली ऐसे फ्री मत करो, बट कंप्लीटली बंद करना भी ये सबसे ज्यादा गलती होगा सर. एडवर्टाइजमेंट कंप्लीटली बंद करना ये सबसे, वी हैव टू चूज वन among two wrong things. दोनों चीजें बुरे हैं, बट अपने को दोनों में से एक कम बुरी चीज चुनना है, तो सर आई विल गो ओके स्टार्ट एडवर्टाइजमेंट.
Any more
But with
questions?
some ethics and regulations.
Any more questions from the judges, please?
No.
Thank you, Dr. Pradeep Kumar. It was a very wonderful talk from your end.
Thank you, sir.
We go back to Dr. Indira Sahajwala. Madam, please unmute yourself. Indira, madam. Dr. Vijay, anything? Any positive development?
मैडम आपका टॉक चालू कीजिए.
Madam, please start speaking. We will try to understand whether we are able to.
Yes. Shall I speak?
Yes, madam. That's wonderful. Wonderful. Yes, please
Oh,
go ahead.
very nice. Very nice. Thank you very much. I'm Dr. Indira Sahajwala. Actually, I am talking on the topic which is not really of medical profession. It is a general subject, social subject, where people have started living together in even before the marriage, and they call it as a live-in relationship. Now, what is a live-in relationship, or what is after marriage relationship? Now, these things appear to the same. It talks, I mean, they have same relationship as husband and wife, or as a two friends. But there's a big meaning attached to the marriage. What is the big meaning? That is that you are announcing to the people that we are together. We are responsible for our progeny. We are responsible about the family. We are responsible about our society. So when they are married, that means they need legal attachment, they need physical attachment, and they have various responsibilities. When they are living in relationship, that means they got no responsibility whatsoever towards anyone. And even to the society, they are not answerable, because they have discussed with themselves that we are going to live like that, and they do not answer any question, and they are not responsible for any legality also. In case they have a baby, then also they do whatever they want. They divorce, or at that time they get married. So mostly the situation is very bad. I feel this is going on since ages. It's not a new thing. In fact, about 25 years ago, when I went to Vancouver, Canada, that was the first time I came to know that people are living in a relationship. And even the university was providing the accommodation to such students. So the second time I read about the Cambridge University, actually that was the first university who allowed boys and girls to live together in living relationship. So anyway, Cambridge University has been always first in so many things. So this university has been doing for the first time. So now my views, I'm going to give you I'm not talking as a medical professional. I'm talking as a general person in the society, as a senior person, what I would feel right or what is wrong. I feel such a thing should not be there, because a lot of side effects are there. It's not just having sex and living together. You are not responsible to the families. You are not responsible to anyone. You are living together just for fun. So that means you are already thinking that pick up and leave, pick up and quit, pick up and quit. You can change as many partners as you like. But there are many people get married also, and still they do 2-3 years they get married and then divorce. In fact, they already decided that they are going to divorce after some time. So that is still better than just without giving meaning to meaning to their relationship. So I'm very much against that, because they bear no responsibility when a child is born and child is left here and there and not looked after. And not only that, see, the brain is very, very sophisticated. It is superpower. Whatever we are uttering, whatever we are doing, we are not getting away from it. We may be able to get away from the people, but it has definitely has got effect on our own brain. So when we are having such things, it is going to damage our own brain. You are going to definitely decrease your intelligence. You are going to damage your neurons. You are removing, you are partially suffocating your hippocampus and amygdala and the frontal cortex, which is supposed to be CEO of the brain. This I understand. I hope you people understand what I mean. That left frontal region of the cortex is communicated with the is aware of everything what is going on and is ordering according to the memory from the hippocampus and amygdala. So that is the thing. It has lot of effect. People get away that who knows what happens. But what I have realized after studying so much about this, that whatever we utter, whatever action we do, it has definitely effect. You may get away from society. We may get away from all other social people, but it is going to have effect on your own brain, own brain. You are going to degrade your brain. You are going to decrease your brain, and your behavior will be according to your brain capacity. You are bound to get mental problems. So I'm of the view, thinking about your now own self. I'm not talking about the society. I'm not talking about the children. I'm not talking about to the community, but thinking of your own brain. You are damaging your own brain. You are not doing the right thing. So it's better to get married, even if you have decided that you will get married only for 2-3 years and then quit it. So it's still, that is better than not marrying at all and living like that. So this is my view. You may accept it or not. I really don't know. But according to brain science says that whatever you do, it has effect on your own brain. So you will have some mental problem. So get away from it. And what more? This is, now I want to know your views, what you thought, what you think, what I'm saying. What are the people who agree with me? You have any questions from me? Please ask me, because I have read a lot of brain. Last time I had given this lecture, a J.J. Merchant oration, where brain and body and spirit health was involved. So after that, I got more interested in the brain activity. And so I'm coming to the conclusion that whatever work we are doing, it is not for anybody else, for your own health, for your own brain. You are doing good or bad. It will benefit you or deter you. So I'm leaving it to you, whatever you decide, and it's your own choice. But hearing the extensive studies of the brain and the scientists, it is the conclusion that it is going to have effect on your own brain. You want to have healthy mental status, so please refrain from such activities. So
Thank you, madam.
I will give to you the thing, let me know.
Thank you, Indira, madam. Thank you very much for your wonderful talk. Any questions from the audience?
I can finish it up, or I want to give more.
Questions from the audience, please.
Yes, question answers.
Any questions from the judges, please? Dr.
No,
Bhandari, sir.
yeah.
Madam,
Yes,
from you of
yes,
the
sir.
rising divorce number, would you not advise young couple to have live-in relation for few years, see the compatibility, and then get married? Will it not help their brain, and will it not save them from all the legality and spending all the finances on getting divorced?
It will be definitely every part of the body, every part of the society, every part of the family, every part of the community will respond to such abnormal behavior. And it is why I am saying that it should be stopped, because this abnormal behavior is now taken as a normal behavior. So we are not animals, we are higher people, understanding people, educated people. So we should follow the good path, which should be, set example for the society and the junior people. Otherwise, our morality will go down. I don't know whether you should attach morality or not, since it is becoming normal thing. So, but anyway, the giving inferior quality of the life is going to have effect on this future generation. So we will not advance. So our mind will be diverted to other activities instead of doing in your profession or you're doing your own duty. So healthy lifestyle is much better than, no one will say it is a healthy lifestyle, living in a relationship. Nobody will agree. Definitely.
Thank you, madam. Thank you, madam.
Hello, madam.
Yes.
Madam, Dr. Anil Pasnekar over here.
Yes,
the way you said it is a mental disorders. So those who are all listening, they will definitely refrain from it, of living in a relationship. I hope so. So the thing is that what should be done to stop this menace of living in relationship? Because you are watching that more and more juniors, with young boys and girls, they prefer living in relationship rather than marriage. So what do you like to say? What should be done?
I did not catch the question from your side. What is the problem on his side? I still don't understand. I'm very sorry. I cannot catch what he wants to know.
The more and more young couples, more and more young boys and girls.
Yes.
They believe nowadays in the living in a relationship. So what steps should be taken, you think, to stop this menace?
What about the couple? But even the couple has to do the normal things, no? They have to go according to the society, according to the science, according to...
Some rules and regulations should be formulated by the government.
I'm not able to understand your question. What I mean that whatever activities we are doing, it has effect on your own brain. You are going to have definitely some problem later in life. So it's for your own benefit and the benefit of the society, benefit of your parents, benefit of community.
So you believe? So
follow the
you said it is a mental. So you said it is a mental disorder, right? brain disorder.
Thank you, Dr. Indira Sahajwala. It was a wonderful talk from your end. We close this competition. We have our judges, Dr. Girish Plat sir, Dr. Vijay Punjabi sir, Dr. Prakash Borana sir. They are just trying to come to some consensus. In the meantime, I would like to show you the rotating trophy that we shall be giving to the winner. This is the prestigious rotating trophy in the name of Dr. V.H. Salaskar. I request our President, Dr. Jitesh Mehta, to say a few words. Over to Dr. Jitesh Mehta, please.
Thank you, Dr. Arvind.
Yeah, Dr. Jitesh, we would like to know your opinion on live-in relationship.
Yeah, that's what I was coming to. On a lighter note, this is a hot topic of discussion for all the senior citizens, you know. So it's like those who have missed the bus or the grapes are sour or something like that. I'm sure most of you will agree on that. It's a very interesting topic for us to discuss because there are all things are all guesswork for us, you know.
No, it is a practical work, sir.
Sorry?
It is a practical work.
Yes. Okay.
Not guesswork.
Let us give some time for the judges to come to a conclusion. Meanwhile, I would like to just
for what?
Come to a very sad topic of today, and that is the passing away of the nightingale of the nation, Lata Mangeshkar Didi, Lata Didi. She has passed away today at the ripe age of 92 years, and the nation mourns her passing away. Let us all pray together. Let us all give her a standing prayer. I request all people in this hall to please stand up and give her a. Let us pray in silence for the departed soul so that she can have peace in her heavenly abode. A 2-minute silence, please. Om Shanti. So the nation has lost a very major finger of the film industry, and of course she has sung for many industries. The Nightingale of India, yes, of course. And we shall always listen to her and remember her all the time. Our judges are almost coming to a conclusion of the winners. Dr. Punjabi sir, would you like to make some comments on the speakers? Please come up this side, on this side of the screen. Yes. Yes, Arvind.
Thank you, Dr. Jitesh. It was really a very sad news for all of us. Lata Mangeshkar, the Nightingale of India. The voice that soothes our ears, our heart, and our soul. We come to the end of this BIMA extempore elocution competition and Dr. V.S. Salaskar rotating trophy, and the prizes awarded by Dr. Lalita Rao. I request our senior most judge, Dr. Vijay Punjabi sir. We affectionately call him Gurudev. to announce the results of this competition. Over to Dr. Vijay Punjabi, sir.
Thank you, Dr. Arvind.
Jai Gurudev Teri Maya.
At the outset, I first offer my heartfelt condolences on the loss of Nightingale of India. We have lost an eminent singer, which is beyond repair. It will not be replaced by anyone, and we all hope and pray that her soul rests in peace. Thank you very much. And now I will announce the results of today's competition, elocution competition. Let me tell you all that the competition was very tough. And this is the first time we are having online competition. Of course, this was an experiment. Second time. Second time. Anyway, I stand to correction that, but I think still we need to improve on this. The online competition has got some problems, but whatever it is, under the circumstances, it was worth the while, and I congratulate and thank all the participants who have come here, taken all the trouble, as well as who have done online. And of course, the competition was very tough. We have 5 competitors, and it was really difficult for us to select the winners. But as you know, we have to select somebody. So we have tried our best. My judges, Dr. Borana, Dr. Lad, they have put all their efforts, and I hope everybody is satisfied. So I'll first announce the third runner-up. Second runner-up. The third prize.
Yeah.
It's the third prize, and the second runner-up is Dr. Anjali Patil. She is here. Fortunately, she is here. Dr. Anjali Patil, thank you very much.
Vijay,
थोड़ा आगे जा, थोड़ा आगे जा.
Vijay, come on the stage. Vijay.
Vijay sir.
And the first runner-up is Dakshini Kashyap. Is she here? Yes, please. Dr. Dakshini Kashyap, please come here. And the Celestial Trophy goes to none other than Dr. Sachin Patarkar.
Sachin Patarkar has to be great.
Anil.
Yes. बोलो बेटा.
I think hold the trophy.
IMA का बैनर है उसके साथ, फिर IMA के बैनर के साथ।
सचिन जरा असं
Yes. All the 3 winners.
I request all the 3 winners to please come on the dais. Anjali madam, please. Sorry.
Yes. And the 3 judges.
Yeah, madam. Today.
अनिल
एक प्रेसिडेंट सर नहीं आ रहे। अरे मैं इधर नहीं उसमें जाने
नहीं आ रहा है।
और क्या चाहिए?
नहीं वो पेन अभी एंड विजय डॉक्टर विजय
यस यस
नहीं दिख रहे
थोड़ा सा
अनिल मुझे थोड़ा
थांबा एक मिनिट थांबा सर
थोड़ा मागे यस
थोड़ा
थैंक यू
Congratulations.
And thank you to all the judges. Vote of thank you.
It was a
Thank you.
It was a wonderful performance from the audience and everyone. I request Dr. Vijay Karanchkar to propose for today's program.
Good afternoon all. We have a great session today, webinar, and after that, elocution competition. I would like to thank our speakers of today's webinar, Dr. Rohit Pai, Dr. Avya Bansal, and Dr. Sajuddin Mirza Attar. I also thank our knowledge partner of the day, Intas Pharmaceuticals and GlaxoSmithKline Pharmaceuticals. I thank Mr. Dipen Mehta, Mr. Siddharth Dinge, and Ms. Vaishali Tanpure from DigiShield, who have given us the platform for this webinar and handle all technical details for the same. I thank Dr. Anil Awad, President-elect, for conducting this webinar smoothly and effectively. A big thank to the past President, Dr. Anil Pachnekar, for being MMC observer for today's session.
I'm still there.
Yes, sir. Thank you to all participants and our honored judges for BIMA Doctors Elocution competition. And last but not the least, I thank all delegates for participating in this webinar in large number and making this a grand success. Thank you to all.
Thank you.
Thank you.
Thank you, everyone. Thanks a lot. Really enjoyed.
Thank you.
Sir.
Yeah, sir. Enjoy.
अरे आपको यहाँ होना मांगता था.
Yes, sir. Enjoy the day.
Okay, yes.
From the start to end.
मजा आया. Yes. अरविंद भाई आ जाओ, चेहरा दिखा दो. सर ये हमारे नेता है.
I am observing the observer Kumar cannot be there in Shivaji Park taking a round.
अरे सुबह से था पावर में से ask everyone. I will not show the who are along with me.
क्या बोल रहे हैं बोलो क्या सर बोल रहे हैं
काय रे अनिल काय म्हणतो
अरे मजा आली की नाही स्टार्ट बसून आहे की नाही स्टार्ट टू एंड
कोणाला बोलवायचंय
अरे स्टार्ट टू एंड आहे की नाही मी अरे सुरुवाती बसून आहे की नाही स्टार्ट टू एंड
काय म्हणालास
अरे स्टार्ट टू एंड मी आहे ना
सासू
अरे स्टार्ट टू एंड सुरुवातीपासून जे आहे तो हळदी उमत कर
अरे मला तुझं काय बोलतोयस ऐकायला येत नाही मग
अरे अरे म्हणता ना तुला स्टार्ट टू एंड आहे की नाही
हा म्हणजे रेकॉर्डिंग ना
प्रोग्रामला
कोण आहे की नाही सगळे तू ना जब तक सूरज चांद रहेगा अनिल तेरा नाम रहेगा बस
भारी भारी
नाही अनिल क्रिएटेबल आहे मला ते म्हणायचं ऑब्झर्वर युजली असं राहत नाही बट आय एम ग्रेटफुल टू यू फॉर बिंग ऑब्झर्वर नाव ऑब्झर्व सायलन्स थँक्यू चलो बाय ये बंद कर रहे
Thank you very much. Yes. बोल रहा है भाड़ा लगेगा भाड़ा लगेगा